Good morning and welcome to the March 2022 meeting of the Adults and Health Committee of Cambridgeshire County Council. Welcome to everyone in the room. We have today got Councillor Jerry Bird back with us for the first time in several weeks after a health scare, and I'm particularly pleased to see you here, Jerry, and I'm sure that's on behalf of everyone in this room and all the different party groups. Welcome back. We also have Dan with us from Democratic Services as Tamar is just temporarily, but she's unwell today. So thank you to Dan for standing in for her. I'd like to, as ever, announce that filming and photography is allowed at all our meetings of the council, so please feel free to take pictures and to tweet during the meeting, though I do ask that everyone present turns their mobile phones to silent or vibrate whilst the meeting is taking place. Please be aware that this meeting is being live streamed and that a recording of the meeting will be available to view on the County Council's website. Usual housekeeping points. To register your wish to speak, please raise your hand. Co-opted members and officers attending virtually can do this by clicking the raised hand function on Zoom and turning on their camera. Also, in accordance with our constitution, I will briefly adjourn the meeting for a comfort break if the meeting exceeds 2 hours, with a little flexibility either way and your understanding. There's no fire alarm test scheduled for today, so if the alarm sounds, I will adjourn the meeting and we will all make our way downstairs out of the main entrance and turn left. The muster point is at the far end of the building. I'm pleased that most of our senior officer team are present with us physically in the room, so that's great. That you are able to be so. Some of the presentations will be by officers joining us online, and we are still subject to the number restrictions in the room because of advice about COVID, and therefore this afternoon our district members in the health scrutiny section of the meeting will be joining us online. I also should announce that there's been agreement between the Adults and Health Committee and the CYP Committee that where child health issues are concerned on health scrutiny, that the spokes from the CYP Committee are invited to our committee, and so that is enacted today. I'm particularly pleased to welcome the chair of that committee, Councillor Goodliffe, who is joining us online. And the other spokes, at least one of them will be joining us, who is joining us physically, Councillor Goodliffe, and like any member is welcome to take part in our meeting this morning as well, although of course not vote. The other spokes, or at least one of them, will be joining us online. They were given the choice about whether to be here physically or to join us online. I think, yes, I think that's everything that I have to say. So we now move to apologies for absence and declarations of interest and announcements. Are there any apologies for absence, Dan?
None received, Chair.
Thank you. Anyone else know of one? Yes, Councillor Bowden.
Thank you, Chair. My abject apologies, but because of an unavoidable personal appointment, I'm going to have to leave the meeting quite early today.
Okay, thank you for telling us in advance. Any other apologies? Thank you very much. Does any member wish to declare any disclosable pecuniary interest or non-statutory disclosable interest? Can we take it as read? There are a lot of members of the GCP here. I got one laugh for that joke. Two, but there are no declarations of interest otherwise. There was a very long roll call. This is for the officers. There's a very long roll call of people declaring that they were members of the GCP in different respects at the full council meeting on Tuesday. Right, item 2, minutes of the meeting of the 13th of January and action log. We're being asked to approve the minutes as an accurate record. They're on pages 5 to 22 of the agenda pack. Any question of accuracy of the minutes from anyone? So I see no objections, so they'll be carried unanimously. An updated action log is also included in the published papers for this meeting. It's on pages 23 to 25 of the agenda pack. Are there any questions or comments on that? Yes, please.
Can I ask about the provision of NHS dental services in Cambridgeshire? It seems very frustrating that the NHS England has been chased 3 times now, and we still have no update on what's going on.
Jyoti.
Got it. Thank you. That's a matter of scrutiny, and I think we can put that on the scrutiny agenda and ask the NHSE to come in and report to that item.
I think when Kate is here this afternoon as well, it might be useful, thank you for saying that, by the way, but it might be useful also to raise that point again. So I'll just make a note that we do that at the start of the scrutiny section in the afternoon, because she's been the person who's been doing the chasing. I saw another hand here somewhere, did I? Yes, please. Okay, thank you. So we'll revisit that at the start of the afternoon session. Any other questions or comments on the action log? No, so it will take the action log as noted. Item 3, there are no petitions or public questions which have been received this month. So we move to item 4, COVID-19 update. This has been a regular item that we've asked for some time now. Jyoti, we're extremely happy that you give us updates, even happier of the work that you and your colleagues in your team are doing. The report is on page 27 to 30 of the pack, but essentially it's the slides that we'll all be looking at that Jyoti will speak to. Jyoti.
Thank you. Rhian, could you project the slides, please? Okay. What I'll do today is to give an update on the government's advice on living with COVID and follow that up with an epidemiological report and what's happening locally and what that all means for us. So next slide, please. There are 4 main components to the revised guidance. They are living with COVID, and that's mainly heralding the removal of all mandatory COVID restrictions. There's a section in there that's about protecting people who are most vulnerable, and the mainstay of that is vaccination, but also there will be targeted testing for people who are particularly vulnerable, and that will be mainly to inform the use of antiretrovirals. There's a section that's about learning from what we've already experienced and some of the good things that we've managed to do through COVID. And then there's a section that's about maintaining our resilience and continuing with surveillance and maintaining contingency plans, as well as the max vaccination programme. Next slide, please. So the policy changes that were introduced from the 24th of February include the removal of the requirement to self-isolate if you test positive, as well as the requirement for contacts who are not vaccinated to isolate, and the testing requirements for those who are vaccinated. So all of that has gone. So because there's no need to self-isolate, the self-isolation support payments have also gone, and we are no longer contact tracing because the people who are contacts don't need to isolate. So that has also stopped. Could I move on to the next slide, please? From the 24th of March, there's further removal of the COVID-19 provisions for statutory sick pay. So that will go. And then from the 1st of April, the main thing that will change is the access to universal, both symptomatic and asymptomatic testing. So people from the 1st of April will no longer know whether they've got COVID or flu or a cold. And we will also, the testing has also been an important part of catching asymptomatic carriage. So that will also go from the 1st of April. We're expecting further guidance from the government on how we can protect the public, what advice we give to the public and businesses, and so on. So there is further guidance expected. And then the other thing that will go is the COVID pass. Could I move on to the next slide, please? There will be further vaccination. So there's an over 75 programme, a spring dose as it's being called, that will be targeted at those who are most vulnerable, so the older population. We are concerned about waning vaccine immunity, particularly for those who are older, as they were the first to receive their vaccination too. Also now being introduced is the offer of a dose or 2 doses for those who are 5 to 11. So that's not for people who are vulnerable, kids who are vulnerable, but for all children. But we are also keen to maintain the usual childhood vaccination programme offer, which has uptake has dropped for those. So that's an important part of our protection offer for children. Next slide, please. So what's happening in terms of COVID epidemiology? I'm afraid it's not good news. We are seeing, and this is national data that you're seeing here, we are seeing an increase in deaths, so that's up 2% nationally. We are seeing an increase in admissions, and that's up about 17%. And we are seeing an increase in the number of tests conducted. So when the policy changes were announced earlier in February, we saw a sharp decline in access to testing. That is increasing again slightly now. And so the drop is also associated with a drop in those testing positive. You know, obviously, as people don't take up the test as much, we're not going to identify positive cases as much. And the increase now is probably reflective of more transmission across the population. And so people are accessing symptomatic testing. I'll move on to the next slide, please. As testing uptake has reduced, the testing data that I would have shared with you previously and the numbers testing positive through testing has become a less reliable source of information. So we are now looking more at the National COVID Infection Survey as a more robust source of information on testing, of COVID positivity rates. That it relies on a random sample of the population who are PCR tested. The downside of this is that it's not as timely as the testing data, and there's a couple of weeks lag in the data. But this data is showing that for our region, we are in fact seeing an increase in COVID rates with a modelled estimate of about 4.6% of our population having COVID. Can I move on to the next slide, please? What we're seeing here is that the number of PCR tests taken up has declined. That they're the bars. The proportion of those testing positive, that's the line, is in fact increasing. So of the people that are taking up tests, which has reduced, many more are actually testing positive. So that's a further indication of increasing rates locally. Can I move on to the next slide, please? These are hospital admission rates. These are also a little bit out of date, but further data, which I can't share with you as it's official sensitive, indicates that there has been, in fact, a further increase in hospital admissions. Some of that will be incidental and reflective of high rates of community transmission, but we are also seeing an increase in the numbers that are being admitted because of their COVID. Next slide, please. Deaths remain fairly stable locally, and we've seen 7 deaths in Cambridgeshire in the last 7 days. Next slide, please. And this is another a projection of deaths. So these are, the other one was the number of deaths after 28 days of a diagnosis. These are the deaths with COVID on the death certificate, and again, a fairly stable and fairly low. Next slide, please. These are the school age vaccine uptakes. So for 12 to 15-year-olds, we're continuing to see a slow and steady incline in the first dose. And the second dose, of course, is reflective of what's happened with the first dose. Particularly of interest here are the lower rates in Finland, which are lower than the regional average. Next slide, please. And also for the booster vaccination, we are continuing to see a steady increase. And I think that's a testament to the hard work that's going on around the vaccine hesitancy campaign. And it is worth continuing with that, because even small increases are worthwhile. What we are continuing to see is Cambridge lag behind the national and regional average. We didn't see that for the school age vaccination programme. And to me, this suggests that this gap is more to do with inaccuracies in the denominator. And we may see an improvement once the denominator's cleaned. Could I move on to the next slide, please? This is a modelled estimates of BA2. So the likely culprit for the increases that we're seeing regionally is an increase in the spread of the BA2 variant. And you can see that in East of England, we are seeing increases. Next slide, please. This is the UK HSA data on or assessment of the BA2 variant, and this is suggesting that BA2 does have a growth advantage over BA1, and the model prevalence of 82% suggests, backs that up. And that advantage is likely to do with the higher transmissibility of BA2. It's unlikely that there is vaccine escape from BA2. The vaccine offers similar level of protection against BA2 as it does to BA1. And their assessment, UK HSA assessment, is that BA2 is also not any more severe than BA1. So the bad news is that it's spreading and it's causing an increase in the rates that we're seeing. The good news is that it's not more severe, and the vaccine does offer a similar level of protection. So I think that's the end of my slides, and I just wanted to reflect on a bit on what all of that means for us locally. We have now stood down our major incident response due to the fact that we are not seeing the levels of deaths or hospitalizations that we have seen with previous waves of this virus. And because it wasn't causing as many hospital admissions, it wasn't causing the level of pressures that we were seeing, we agreed across the system that we could, in fact, stand down our major incident response. And my team is now working towards normalization, and that means handing a lot of the management of outbreaks back to the UK HSA to manage, and allowing my team to pick up the day job that has been neglected for the last 2 years. However, this is still a nasty virus. It does cause people to be unwell. We are starting to see hospitalizations increase. We're seeing death rates increase nationally. So there is still a need for us to be careful. And I am advising that we maintain the precautionary approach that we've been taken, and that is consistent with the national guidance. So whilst the national guidance removes mandatory requirements for self-isolation and mask wearing and social distancing, etc., it does recommend careful use and appropriate use and local variations in that use. And because we've got high rates, I would advocate that we do continue to take a precautious approach. Because this can cause you to be unwell, I think there are still risks to business continuity. That's a message that we will be pushing with our local employers. If you do have people who have symptoms, please send them home, because otherwise you risk this passing through your workforce and many of them having to be at home because they're unwell. And again, for us as a council, I'm advising that we don't completely normalise, that we do maintain social distancing, and that we wear our masks, and that we continue with testing whilst testing is freely available. As we move to the 1st of April, we will be much more dependent on people with symptoms staying away from other people, both in the workplace, and staying away from vulnerable people. For example, in care homes, it would be very unwise for you to go and visit a loved one in a care home if you have symptoms of COVID. So that's the approach we will be taking. We will be absolutely dependent on people who are unwell staying away from other people after the 1st of April. So that's the approach that I'm continuing to advocate. I know people are sick and tired of this virus, as am I, as are my team. But I couldn't, with any degree of integrity, say that we should drop all of our precautionary measures, because this is still a nasty virus. And I'm happy to take questions.
Thank you very much. Councillor Wilson.
Thank you, Jyoti, for that update. It's very helpful for us to get it. I'm presuming you're going to share your slides, because there's a lot of, I'll put them on the web or something, because there's a lot of really useful information there. A few points from me, and you might actually want to pick other points up from other people rather than necessarily deal with me, so that I'm not seen as hogging it. I must admit, I've forgotten what BA1 and BA2 variants are. Is this what I commonly known as Omicron and Delta? Yes, I think you know. Well, I'm sorry, let me go through the others.
The BA1 and BA2 are both variants of Omicron.
Fine, okay, thank you. And I gather Chris Whitty is always keen to talk about excess deaths rather than deaths. So are you able to clarify what that means for Cambridgeshire? I can understand about the advice on people staying at home and taking precautions. Do you get frustrated when you go into shops and other places of work where people are not wearing masks when they walk around? And do you challenge them or their managers, or should we? It's very frustrating when the government is saying you don't have to do this, but then it's providing advice that, well, you should really. And then the most important thing, I think, is you said at the beginning about we need to start learning from what has happened. So is the County Council doing a formal lessons learned study? And if you are, what have you discovered so far? Thank you.
Good questions. Councillor Bowden.
Thank you very much indeed, Chair, and thank you to the Director of Public Health for the presentation. 2 points I'd like to make. Overall, I very much welcome the lifting of restrictions which is taking place. It's going to be essential that we learn to live with COVID, just as we have learned over the years and decades to live with flu. But I've got 2 points to make on that. The first is that it's still a dangerous disease, quite clearly. And I really welcome the additional work which is being done on the vaccine programs, both for the very elderly and for the young. And those initiatives, I think, are really important ones. And I hope to see them being promoted as much as possible, both by the County Council and by those to whom the County Council communicates. I think promotion of those vaccines is really important to those relevant groups, or for those relevant groups. But it's also important, and I think we've lost the initiative on this, and I'd like to see it to be being regained. It's important to encourage people who haven't had their first dose, their second dose, or their booster dose. It's important to encourage them to continue to start actually taking those doses, to complete it if they haven't completed their booster dose, and to start it if they haven't even had their first dose. COVID is not going to go away, and there is still a real value in people completing their immunization process, or even starting it if they haven't already done so. And I don't hear that message coming across, and I think it's a message which is an important one which we should put across. The second point I'd like to make is to do with what the Director of Public Health called normalization, and the potential contradiction between normalization and a precautionary approach. Now, to the extent that we can say anything is good about this disease, we can at least say that BA1 and BA2 have been mercifully substantially less serious in their effects than previous variants that we had of COVID. And that is a matter of great relief to us all, especially given the higher transmissibility that both BA1 and BA2 had compared with previous variants of the disease. And that can lull some people into a false sense of security, so it's important that that doesn't happen. But at the same time, we do need to understand that we have to live with COVID. And living with COVID may mean, yes, more mask wearing than we would personally really like to have, but it's a relevant and sensible precaution to take in many circumstances. However, the danger is that if we overplay the seriousness of the current situation, that we lose the authority to speak if things do get worse again in the future. And by that, I mean, within the local authority context, we are failing to return to the normalization that the Director of Public Health said, but failing to return to a more normal way of doing things on a day-to-day basis than is the case in the outside world. And if we continue to operate under guidance which is stricter than may be absolutely necessary, then my fear is the following: that it is distinctly possible, by no means certain, but distinctly possible, that we're going to see further variants of concern which are a lot more serious in the final outcome than Omicron has been. Let's hope not, of course, but it's a distinct theoretical possibility. And if we do find ourselves in that situation, we are going to need to have the confidence of the public as far as possible in the messages which are coming out from public health. We will desperately need their cooperation, and the Director of Public Health made the point, people are weary of COVID, but that weariness will have to be overcome if we find ourselves in that situation, which is far from impossible. And I implore public health within Cambridgeshire and Peterborough not to overplay things at the moment, not to over dramatize what the current situation is, so that we continue to maintain as much credibility as possible with the public if, and let's hope it's not the case, but if we find ourselves in that dreadful situation where we're going to have far stricter measures brought in. Thank you, Chair.
Thank you, Councillor Bowden. Councillor Gay.
Thank you, Chair. I have three points that I'd like to make in response to the Director of Public Health's presentation. First is about the increases in deaths and hospitalizations that we're seeing at the moment. It's clear that many of those are coincidental, and that many of these individuals are being admitted for other serious conditions. And this is clear both from the fact that there is not a lag between the increase in cases and the deaths and hospitalization, which you would expect if the virus was causing the conditions they're admitted for. And secondly, to Councillor Wilson's point, we're not seeing any increases in excess mortality at the current time. In fact, the excess mortality is tracking below 5-year trends at the moment. Second point is to do with waning protection from vaccination. This is often measured by humoral antibody, presence of humoral antibodies, which is easy to measure. This response wanes naturally, but it leaves behind memory B cells and T cells, and these are the responses which are very difficult to measure, which are required for protection against serious disease. Another point that I think is really important regarding children who are not affected to any great extent by this, it's very important that they have exposure to the natural disease, so they develop natural immunity to the virus. And the third point I want to make, I'm surprised the Director of Public Health has not mentioned the situation in Hong Kong. Hong Kong has taken a very severe suppression strategy. It has very low levels of vaccination in its elderly population, and that vaccination has been done with Sinovac, which we know to be less effective than the mRNA vaccines, which most of us have had. And very sadly, they've seen very high rates of death amongst the elderly population in Hong Kong. And what this shows, quite interestingly, is that the suppression strategy is selecting not for increased pathogenicity, but for increased transmissibility. So therefore, I think we have to think very carefully about how we deal with the public health issues arising from COVID in the future. But clearly the profile of pathogenicity of the Omicron virus is not significantly different to the original virus that arose in Wuhan. So that's my contribution.
Thank you. There are lots of good questions here. And in an ideal world, I'd have a break, have some answers and then some more, but we have got a very full agenda today, so I'm going to steam on and just ask Jyoti to take a note of questions and come back at the end. And I'll just ask speakers if you can stick to about 2 minutes. I won't require it, but if you can, it would help me. I've got 5 more speakers down. Councillor van der Ven is next.
Thank you very much. Yes, I'm sure we're all aware, especially as councillors out in our communities, of the prevalence of COVID and especially the terrible impact on people with pre-existing health conditions and the really unspeakable circumstances that many people are suffering. I wanted to ask in particular about schools. And to thank you and your team and John Lewis for the reporting that he's been doing on a regular basis to keep us informed. We understand that that can't continue anymore. But with the transition ahead, are you confident that schools which are still obviously suffering real disruption, in particular to their staff who need to be there every day, and then their families and so on and so forth, that they will have the support that they need from UKHSA as your team reverts back to its other work? Thank you.
Thank you. Councillor Murphy, please.
Thank you very much. I've just got an observation and a couple of questions. One observation is that although this variant is less severe, it is much more infectious. It's even more infectious than BA1, I believe. And those two things can cancel themselves out. And so the lethality overall can be, very similar. So it's still a matter of public concern. And I appreciate the work that's being done on this. Question. You have cited harms as risks to business continuity and also number of deaths. But what weight is given to the long-term illness and chronic conditions that are actually caused by COVID? These present challenges to people and of all ages, in fact, but also present as requiring our services and those of the NHS. So I'm just interested to know how that features as a kind of risk from this virus, albeit lesser severity at the moment, although higher rates of infection. The other question is, I completely understand about standing down the critical response, but we do unfortunately need to be ready to restart because, as Sage has pointed out, there are, say, 4 scenarios for how this can all play out. There's actually no reason to believe that the future variants are going to be less severe, and they could easily be much more severe and resistant to vaccine, and therefore we're back to where we started from. So it may be a bit early to learn lessons completely, but certainly for we have to be ready to restart. So I'm sure that that's your view, but I just wanted to make that point. Thank you.
Thank you, Councillor Daunton.
Thank you. I wonder if we're tracking incidents of long COVID and whether we're taking part in any research projects concerning long COVID.
Thank you very much. Councillor Slatter.
Thank you. I personally was pleased to get information from officers about the vaccination, both childhood routine and also encouraging first timers for COVID. It may depend on what you're getting from your district council, I don't know. What I had to raise was a practical point. I had some slightly inconclusive correspondence about valves in masks, and I think it's even more pertinent now as we try and live with COVID. I think it's going to be one of those things whereby people can protect themselves and also give a message to others. Now, I can understand why the public health advice was not to suggest using valves, because they don't protect other people. But sometimes people need to wear the sort of protection that is for themselves or for the people they're going to mix with and they don't want to pass it on to for various reasons. So I think we could do with something a little bit clearer about valves. Because if I see somebody wearing one with, a mask with a valve, I can see that it is clear that they are concerned for some reason or another, and I might modify my behaviour. The moment because they're not actually advised for public health, it doesn't seem very practical when we all have to make individual decisions and make individual decisions for the other person you're just close to. So please, could we have something a little bit clearer now about valves? I don't know how you make them yourself, mine, but we can get them commercially. I think you've got one on, haven't you, Councillor Murphy? No.
Thank you. Councillor Bird.
Thank you, Chair. Mine's just a quick one, really. In the presentation, it said about over 75s will have the next vaccine, that number 4, in 6 months after their booster. I'm just wondering what's happening about the clinically vulnerable, because nothing was mentioned about that. Are they going to have the 4th injection or tablet?
Thanks. And a word from me. When we were planning the agenda some weeks ago, I was thinking that we could say this is the last COVID report we'll have. I think having heard what we've heard, we'll definitely need to revisit this at our next meeting. Jody will answer the points. I'm not going to comment on the different points in the debate, but what I have heard is that there is a request really to look at both the lessons and the preparedness. Now, on lessons, we could set up some great big formal thing and have an inquiry and set up a committee or whatever. We could do all of that, but what I'm hearing from the members is that it's part of a normal internal report that we get, and that our officers give us their observations. That's what I'm hearing. So I think July is quite a way away. So I think it could be good to have a report then, not just an update of what COVID looks like at the time, but some of the lessons that we've learned internally, and the preparedness, the point that was made in the last contribution about our preparedness if something bad happens again. So that's in my thinking listening to the debate, and I just wanted to check with Jyoti that accords with what she could and would be desirable to do. Jyoti.
Gosh, there's ever so much there to respond to. I'll try and do as much as I can, as succinctly as I can. I think throughout this, I've tried to be as frank and accurate in my description of what's happening, and I certainly hope that you haven't felt that I've been sensationalist in anything that I've said. And today I've talked about the fact that it's not causing as many deaths or hospitalizations as we've seen in previous waves. But that there is still need for caution, and I think that's quite a balanced response to what we're seeing. In terms of preparing for learning from the past and preparing for the future, I'll cover those off together. When I first arrived, we internally did a look back and used that to sharpen up our response. So that's something we've already done. System-wide, that's something that the Resilience Forum would do. So looking at the different partners' contributions to the response. They've also had an exercise looking at how we would manage ongoing pandemic issues. We are also mindful that a public inquiry has been launched and that we need to be prepared. So we've been gathering our evidence for that in preparation for us being called to submit evidence. We will obviously continue to learn from what we have done through this, and not just for planning for future pandemics, but I think there's important learning for usual business as well through this. You know, for example, how we've worked so effectively with partners to respond very quickly. In terms of resilience moving forward and vaccination, we've continued to support vaccination uptake, vaccine hesitancy, and have been very generous with our conf allocation for that kind of work over the next year. So absolutely supportive of pushing vaccine uptake. It's really an important part of our protection against this virus. And I have also, whilst it's right and proper that the UK HSA picks this up, this is their role. They have also kept staff in till September to manage ongoing risks, so that should help with that. We have also kept some contingency, so I've kept some health protection staff funded through the comp funding over the course of the next year, both for resilience planning, contingency planning, but also to flex should we have increases in vaccine transmission. We're not currently seeing excess mortality. We have in the recent preceding months seen excess mortality in care homes. It's something that we will continue to keep an eye on. And I also did reflect that much of the hospitalisation increase we were seeing was reflective of community transmission. But now we are seeing some increase in acute admissions due to COVID. And as rates increase, we will need to continue to keep an eye on the impact on hospitalizations and deaths. And we do know that as general rates increase, we do inevitably see an increase in hospitalizations and deaths. Long COVID, the CCG have invested in a long COVID clinic. They are continuing to monitor the number of cases coming to them. I think there's more risk with severe infection. We're not seeing particularly severe infection at the moment, but it's something that we will continue to watch, and it is a matter of national study as well. I think I've covered off the majority of points.
There were a lot of points, and you did very well to cover them all. And if any member didn't feel that it was done justice, just contact Jyoti after the meeting, please. I thought that was an excellent discussion. I think it's a very fair challenge. You know, we don't want to, within the council and in the messages the council says, say more than we have to because of the difficulties then if things change. I heard that point, and I think it's a serious point. And of course the challenges that came from both sides of the room, so that's underlines that. On the other hand, I think in the end, the Vice Chair and myself said to our Director of Public Health, you have to call it as you see it. And she's saying that we should continue the precautionary approach, and I've got no hesitation in backing that judgment. And I'm worried, frankly, I'm worried about the lifting of the testing regime, and I'm worried that the extra help for people, poorer people, to be able to isolate is being lost. These are national issues being discussed nationally, but I'm worried about that. And its impact locally, and so I've got no hesitation in it from the chair in saying not just thank you to our public health team, but to fully endorse the recommendations that they bring to us. The formal recommendation is to note the report. Everyone happy with that? Thank you very much. Lots of nods from all sides of the room. Thank you very much, Jyoti. We now move on to item 5, Cambridgeshire and Peterborough Safeguarding Adult Partnership Board Annual Report 2021. And Joe Proctor, the Head of Service, is joining us. I'll just say that I represent this committee on the Safeguarding Board. I regard it as one of the most important things that I do. I've been very impressed by the work that goes on, in particular the reviews that have taken place. And so again, the Vice Chair and myself wanted this issue to be high up in today's agenda because our safeguarding responsibilities is such an important part of what exists for all of us in our work. And Joe Proctor is going to speak to us.
Thank you. Can I just check, can people hear me okay? Yep, lovely.
Yes,
Thank
that's
you.
fine.
Thank you. So the report covers the time period from April 2020 to March 2021, which is obviously extremely retrospective. And I can give you assurances today that the 21-22 report we will ensure is presented to you much earlier on. So it's not looking back a year retrospectively. As you're probably aware, we have a statutory duty to provide an annual report, and the legislation stipulates what the report should cover. The report was signed off by the safeguarding boards in November 2021 and published on our website, and it's been brought to you today for information purposes. The report and the work of the partnership has been scrutinised by an independent scrutineer, and he has provided assurances that both the report and the work of the board is meeting and actually exceeding our statutory obligations, which is obviously really important. Particular highlights of the report, I think, include our response to COVID. As detailed in the report, the board has played a crucial role both in terms of upskilling staff and volunteers during the COVID pandemic. And I think we need to remember this is going back to when we very first went into lockdown, which is obviously a very different place to where we are now. And also the role of communications, particularly about the importance of continuing to recognise and report and refer potential cases of abuse. The executive board and the various boards that sit underneath within our governance structure have also had oversight of the effect of COVID on agencies' resources and the implications that that's had for safeguarding. And I can give you assurances today that that oversight and scrutiny is ongoing. They still sit within a standard agenda item within our various boards and the structures. We've continued to deliver our multi-agency safeguarding programme throughout the pandemic. We're one of the places in the country that have continued to do that. And we've also introduced SWAYs, which are in essence really online virtual briefings that allow people to kind of access a range of, I think we're up to 24 different subjects now that people can click onto and look at their own time so that they continue to be upskilled during the pandemic. The report and the timescale covered it, I think it was sitting at around 10,000 views. We're now actually sitting at in excess of 50,000 views. So we know that they've been particularly important in terms of our upskilling of staff. As Councillor Howitt has rightly mentioned, one of our main functions is our safeguarding adult reviews, and within the timescale covered by this review, 6 safeguarding adult reviews were published. I think it should be noted that all of the deaths within those reviews occurred between 2017 and 2019. So obviously we're now in 2022 and practice has moved on considerably. At the completion of each of those reviews, an action plan is developed, and the board then monitors progress against those action plans. And all plans are either completed or are on track. Learning arising from the reviews has resulted in a plethora of different activity, including policy changes, additional funding, training, work with communities. All the case reviews are shared with practitioners through a series of workshops and briefings, and we also present something called a 7-minute briefing, which is basically gives people a highlight of what the review means for their implication for practice. And just to give you assurances, we do audit against the learning and the recommendations within the reviews to ensure that learning has had an impact on practice. The report only contains a very brief overview of each of those 6 reviews. If you are interested in further detail, they are published within our website, which gives you the full reports in much more detail. But that's kind of just a quick highlight, really. I know that you're extremely tight on the terms of the agenda, so I'll open it up for any questions.
Thanks very much, Joe. Councillor Bowden.
Thank you, Chair. When I saw this agenda item and saw that this report was more than 40 pages long, I have to say my heart sank. Having seen too many reports come through which are less informative than maybe the length suggests that they could be. In this case, I was badly wrong, because when I read the report, I found it to be very informative and extremely useful. I'm a little bit concerned to have read that there were over 1,000 allegations, suggestions of malpractice, which finally came down to 6 reviews taking place. And I read the process by which that winnowing took place. I have a little bit of concern about whether any legitimate and important cases have not been reviewed, which should have been reviewed, but I've got no way of telling whether that's the case or not. It just seemed to me surprising that it finished up with just 6 which were reviewed. And reading those summaries of those reviews, the individual cases of Simon and Claire and Alice and Dorothy and Peter and Alan, I thought was really, really helpful in bringing clearly to the fore what the issues are and what can happen and what should not happen within the organisation. And I fully accept we're looking back up to 5 years here. That unfortunately comes with the territory of the way in which these things happen. But I was particularly pleased. I read through that and thought, yes, individual learning points are being mentioned in each case, but what really happens as a result of those individual learning points? And what I was really pleased to see was that it was mentioned in the report that during 2021, a database of learning has been established. And that can only be a good thing. And my request to you, Chair, is that, obviously not in the very short term, but as it becomes appropriate, could we have a look at how that database of learning is actually being used and is causing changes to take place? Because I think that sort of feedback into the system is absolutely essential. Far too early to do it now, of course, but it will be absolutely essential within the next year or two. And I'd be really grateful if the Chair were to encourage that to come before us. Thank you.
On that last point, if that could be minuted, please, so that because I'm completely happy with what's been said there. No other members? I've got a short contribution myself. Firstly, as Charlotte chairs the safeguarding board. I worry about, in the end, how responsibility is determined. As the report says, the aim of the reviews is not to ascribe blame, it's to be a learning tool. But if it's not there, where is it? And because we're working with so many partners, and often the errors that are there and the mistakes that are there are not of one person or even one agency, the data. And I'm not surprised when things go wrong. If you think of the number of people that we're dealing with and the complexity of the problems, it's inevitable that there will be mistakes. And we've got to be honest and say that. But where there are, I think there has also got to be clarity in terms of responsibility. And I'm worried that that doesn't exist at the moment. So I wouldn't be interested, Joe, in your own answer on that. Secondly, on your point about the audit showing that the lessons have learned, and this is complementary but different from the point that Councillor Bowden made, could you just tell us a bit more about that? Because clearly there's a danger that the lessons don't get learned. So how are those audits conducted, and why are you confident with those positive results? Could you, the points in the report about people with learning difficulties dying 20 years plus earlier than other people in our community are pretty shocking. It's great that we're publishing that and acknowledging it. That's important, so thank you for that. But could you comment a bit, and that this may be you or it may be Charlotte, about what we're doing about that? Because I think that's an important finding in the report. And finally, I listened to the independent person on one of the serious case reviews, who was brilliant, by the way, I thought. I don't know whether that's the same person who, as the independent scrutineer that looks at the report. It isn't. But if what I heard and saw is representative of the role of the independent persons who support us, I think we should say a very, very warm thank you for what they do, because they clearly add to the process and keep us all on our toes, which is an essential part of that process. So again, I'd like to say that, but also hope it will be recorded in the minutes. Jo.
Thank you, Councillor Howard. So just, I think, dealing initially with the element of independence, we are quite unique actually in terms of probably our transparency, in terms of how we run our case reviews and the independent scrutiny, in that there is no, while we have to have independent scrutiny, there is no requirement for us to have an independent person who oversees our case review process. Locally across Cambridgeshire and Peterborough, we have chosen to do that. So we actually have an independent scrutineer, who is the person who has mentioned and done the part within the annual report. But on top of that, we also have an independent chair of both our children's and our adults' case reviews. And that's a gentleman, Councillor Howard, that you're referring to. I think that's really, really good for us, because it does mean that we have got somebody challenging us at every single part of the process, who is not a member of any of the partner agencies. And we're one of the few areas in the country that do that. And it has been recognised as good practice that we do have that element of independence and scrutiny. In terms of the process and the cases that get referred through to us, what I would say again is it's very much dependent on agencies to refer cases through to us for consideration of a safeguarding adult review. We again, in terms of what we look at us nationally and regionally, we do have a lot of referrals that come through. And I think, again, that's very reflective of the fact that as a partnership, we want to learn lessons and we want to look at cases. And I think that's a really positive part of the partnership. In addition to that, what we often get as well is through the coronial process. We may well get the coroner who's had a look at a case that says, actually, I think you might want to have a look at this through your processes. So we do join up with other processes, and likewise, it could come through as the domestic homicide reviews, which again are another series of reviews that are undertaken through the community safety partnerships. Again, I can confirm that there's a good join up between us and that process to ensure that the cases are being looked at in the right place. I'm very much somebody that I don't like to do something if we can't evidence the impact of that. And I have quite a strong background in quality assurance, which for me is where we've got those audits from. And what we do is we do two things really. We audit the themes of the case reviews, which and every 2 years we undertake a themed review, both for children's and for adults. Again, there's no requirement for us to do that. That's something that we've chosen to do locally. And those are the themes for us really that start to evidence. We audit it twice. We look at what the themes are. We do the piece of work to look at kind of what do we need to include. So recently, we've done lots of work around making safeguarding personal. That's things that have come through previous SARS. We're then auditing against that to ensure that it's having an impact on practice. And when we're saying audits, we're not just talking about looking at cases. We also include within that surveys and focus groups with our practitioners and our service users to ensure that we are actually having an impact. Those audits are undertaken within people within my unit, and we are again an independent unit. We're hosted by the local authority, but we're independent of the local authority, which again gives us a further level of independence. In terms of the comments around the blame, I think we need to be quite clear that these are about learning lessons. They're not about apportioning blame, but that does not mean that within the individual agencies that there may be disciplinary processes undertaken, or there may be independent reviews undertaken within the individual agencies to look at blame. But we're very clear, and government statute says to us that we are not to be apportioning blame within these reviews. They are about learning lessons. And I think since we've moved to that process, both in terms of children's and adults, it has given us a richness to the reports that we may not have had previously, in terms of the engagement that we've had both from practitioners, agencies, and also families who are involved in the process. Often what we do see is these cases running in tandem with coronial processes, which obviously have a very different version in terms of what they're looking at than we do. Does that answer most of the questions, Councillor Hammett?
I think Charlotte was also going to come in. Charlotte.
Yes, thank you, Chair. So the point about learning disabilities is a very current one, actually, because we do know that people with learning disabilities experience worse outcomes than people without learning disabilities. And actually, we're in active discussion with the NHS colleagues about that. So we have a system of doing reviews, which is included in the report of people who've died of learning disabilities, but also the CCG has initiated a learning disability, what's called a learning disability summit, which we're using to really take stock of what are the areas where we could be improving our practice. So I think what I would say is there's a much higher level of recognition of this as an issue than perhaps there was a couple of years ago, and there's a real commitment across agencies to taking those issues forward, and the local authority is very involved in those discussions, and it might be something that at some point possibly might be appropriate for scrutiny, actually, because it's very much a health issue and a social care issue.
Again, I'd be grateful if that last point could be minuted. Just before I sum up, Councillor Van der Ven.
Thanks very much. I just really wanted to acknowledge what the report says about the increasing potential invisibility due to moving to virtual support in the voluntary sector and other agencies. And I think that will come up elsewhere in our agenda today. And just to emphasize that that's a big deal. Thanks.
Thank you. Like Councillor Bowden, I think the individual cases summarised in the report are probably the most moving and important element in terms of our learning on this. And I just want to thank both Joe, you and all of our safeguarding colleagues for the function that you do, but also commit our authority as a partner within the process in delivering services to full support for this process. And thank everyone for that. The recommendation is receive and note the content of the annual report. We've got some really controversial recommendations today, folks. Is that agreed? Yeah, lots of nods on either side. Now we move to item 6. We are behind time, officers in presenting, also please be very concise. We've got a number of contractual items. Everyone can ask questions and challenge, of course, but that may go through fairly easily. Item 6, procurement of older
Sorry,
people's...
Chairman. Sorry, Chairman. First of all, apologies for coming in late. Chairman, I would have declared this earlier on. As I am a member of South Cambridgeshire District Council, which is one of the partners here, I will not be taking part in this debate, and I will leave the room because I think it's only fair that I should leave the room on this particular matter. That is my choice, Chairman. I'm not saying that. That's my choice.
It is your choice. Just before I bring any other colleagues in, I'm just going to look at Dan. My own view is, having declared it, that really shouldn't, you may choose to do it, but that really shouldn't require you to do that. I'm just going to look at Dan if he's got any comment.
Sorry. Yeah, that's entirely your call, Councillor. But if you would choose to leave, then please.
So I'm announcing from the chair that any members of district councils affected are having declared it, are welcome to stay in and contribute to debates. But I fully respect if any member chooses otherwise. Please.
I only ask, Chairman, that somebody reminds me to come back in. That's all.
We'll be doing that about 4:20 this afternoon, Mark. Right, please.
I'm also a member of South Cambridgeshire District Council, so I should declare that as well.
I think it's right that we're all learning, but we're going to do more and more partnership working as a council. So we can't, every time a district is working with us, so have people leaving the room. So I'm saying that from the chair. It's great that you've said it, but I encourage members to contribute, having been clear about your district membership, but to contribute. I encourage people to stay and contribute. Otherwise, we're going to have lots of empty rooms as time goes on. Councillor Van der Ven.
I'd like to ask Councillor Howell to come back, because I think we need him. We really need the insight. This is a partnership.
With respect, I have asked him not to leave, but I've said it's up to his choice. So I think we won't push that. I understand your anxiety, but
I think because he's been in the business, he knows what he's
own mind. So we now move to the item, and it's presented by Lisa Sparks, Senior Commissioner for Early Intervention and Prevention, and she's online. Lisa.
Good morning. I hope you can hear me.
We can.
Good. So this paper we are bringing along today to seek approval for reprocurement of the service. The service at the moment is a county-wide service, but is delivered by 3 different providers. Age UK deliver across Fenland, Hunts and East Cambs, South Cambridgeshire District Council for South Cambs, and Cambridge City Council for the Cambridge City area. We are seeking to go for an open procurement for the 3 lots for Fenland, Hunts and East Cambs. But we are requesting that we carry on our partnership approach with South Cambridgeshire and Cambridge City Council, and that is based on legal advice supporting a direct delivery approach with other local government partners, and is also reflective of the significant financial risk from adopting an open procurement for these 2 services due to the level of local government pension scheme employees that are contained within those services. The service is open to all older people across Cambridgeshire, and it supports with a range of things from helping people to access grants or financial information, debt management, access to social care advice or assessments or home adaptations. So it's wide ranging, and the support is tailored to the individual. So our recommendation is to approve the recommissioning of the service for a contract period of 5 years and a total value of 4.5 million, and also to agree to delegate the responsibility to award the contract to the Executive Director of People and Communities. Does anyone have any questions?
We'll take the debate. The first person I see is Councillor Slatter, please.
Thank you, Chair. I'm very happy with the proposals. I need to declare a bias, if not an interest, in that I had years of dealing with the Cambridge City version of this, and a lot of respect for it from seeing it in action. Just a few points coming up from the report. Just being picky, 2.2 should probably say 2021, but I think you've probably seen that already, and it may have gone off the website. The table is very interesting. I'm actually struck by the small numbers. Apart from the referrals to the Lifeline Act service, and 1 or 2 other things, the advice on cleaners and so on, I am a little concerned that there's an underuse of this service. It may be that within the system, calling it the visiting support service, rather than say 65 plus or independent living or whatever, which it's gone by in the past. It's not always visiting. Sometimes it's all done by email, by request. If you're looking after a fairly irascible partner, you don't want people coming to the door necessarily, or even phoning up. So I think that a lot of the support has been excellent, but maybe not enough of it. Maybe the councillors aren't as aware of it as they might be. I mean, this splendid publication, I hope you've all got your copy of the latest one, this independent living. It doesn't really major on the sort of support that can come via the county council and delivered by the agencies we're asked to commission. So if we're commissioning them, I want to make sure they're fully employed, and we know how to get at them, and we know how to refer our residents to them. That's not really clear from the brochure, just how you get to this particular aspect of our services. There was one thing that does strike me is that maybe we're not advertising it enough in the right way, and quite how we do that. Other colleagues may well have a good idea how, bearing in mind that the private providers will be in there with the advertising that applies to the later things on this agenda as well. So I'll stop there. Thank you.
Thank you, Councillor Bowden.
Thank you, Chair. I'm pleased that Councillor Slatter, who I fully acknowledge has more knowledge and experience of this area than I do, I'm pleased that Councillor Slatter mentioned the numbers issue, because that struck me as being very strange. But not being an expert in the field, I was reluctant to raise it, but I do endorse what Councillor Slatter said. Those numbers do look remarkably small. And it's not the only part of the numbers which I found interesting. Earlier this week, and I fully accept that this agenda paper was produced last week, but earlier this week, we in full council passed a resolution where we said that we would be seeking to ensure that we reduced the inequalities that we've got in terms of economic indicators within our area. And what's really interesting here is that there is an inverse correlation between the amount of money provided per district and the amount of deprivation there is per district. And whilst I fully accept that different districts have different sizes, you only need to compare South Cambs, which is the least deprived district that we have in our area, with Huntingdonshire, which is a larger district and more deprived, to see just how stark that variation is. I said at full council, as you'll recall, Chair, that I was concerned that there would be very good words spoken which wouldn't actually follow through into actions. And whilst I can hardly expect the action to take place at this meeting only a few days later, and I'm not going to be that unreasonable, this is an indication of the way in which the actions that this council take do not assist in reducing economic inequality and disparities in the health outcomes that we have between different parts of our area. So I'd like to put that on record. And it is something I will be coming back to in future meetings on future areas. And I hope that once there has been time to digest what has been agreed, I think it was agreed unanimously by full council, that will be better reflected in some of the papers which come before us. And the final point I need to make, Chair, is I was very surprised to see that a consideration as to a local government pension scheme should have a material consideration in determining the way in which a procurement process would take place. That really did surprise me. That doesn't seem to be putting the interests of individuals, the individuals we're trying to help, at the center of the whole process. I'm in no position to make a judgment as to the legality of that. I have to assume the county has got it right. I can't second guess that. All I can say is I was very, very surprised to hear that. And absolutely finally, I did give notice I'm going to have to dash away, but I'm looking forward to hearing what the result of this debate is and future debates today. And I will be following all of those up. But thank you very much indeed, Chair.
It'll be on the website, so we expect you late at night to be watching it, and I'll be asking you questions later to make sure that you have. Thank you.
With respect, Chair, it won't be tonight, but if you ask the questions next week, I will have gone through the whole meeting.
Very good. And for everyone else and everyone watching, that was a light-hearted exchange. Thank you very much. Wish you well, Councillor Bowden. Next, we on that last point, actually, I would just like to say I felt exactly the same about local government pension scheme. I think that it's wrong to have that as a reason. I completely agree with you on that, so I will just say that. Next, we have Councillor van der Ven.
Thank you. Thanks for the report. I had two comments on virtual support, kind of following on from our discussion earlier on the safeguarding report. Virtual support, as outlined in 2.4, isn't always appropriate, I think, for safety at home. Hoarding might be an example of, the actual in-person visit. One will become much more aware of someone's predicament, and that might remain invisible if relying on virtual support. And then a little bit later on, the encouragement for older people to become digitally connected may not be realistic. And I wonder if other avenues need to be sought instead to make this service known. And then going on to the discussion on the contract values, could you just say a little bit about the comment that the amounts allocated to each area reflect the current demand across the districts? This will be reviewed in line with demand trends over the life of the contract. And I wonder how that will take place. And of course, there are some really interesting questions about the individual districts and how these things are managed, because that's where the work is taking place. And it's very interesting to note the retention of housing stock in Cambridge and South Cambs, and I wonder what bearing that has with the in-house provision. Thanks.
I once told an older person's representative my concern. I once told an older person's representative my concern about that you've just raised about older people not perhaps being able to be digitally up across the board, and got really slapped down by that. So it's there's now so many older people. There are lots of people that can and lots of people that can't. It's a fair point, but I just thought I'd pass on that anecdote. The next person that we have is Councillor Hay, please.
Thank you, Chair. I also picked up on the point that Councillor Slattery and Councillor Bowden mentioned, which is the chart on page 77. And I wanted to know what is being done to publicise the fact that we do provide this service, particularly when you look at Cambridge City. They obviously publicise it well there. I mean, so you only have to look at the numbers for, say, for instance, referrals to Cambridgeshire Handyman in 2 quarters, 24 and 26. And yet in the Age UK, it's 7, 12 and 0, which they refer to three places that do have high levels of deprivation. Source cleaners is another one. I was astounded at the number of source cleaner applications within Cambridge City, but then perhaps I shouldn't have been, because within Finland there's not that many people that can afford to hire cleaners and handymen, etc. Which brings me to my other point. We provide this service. Do residents who access these services have to actually pay to get those services?
Thank you. All the questions are being noted. Councillor Daunton, please.
My question was also about 2.4, but from actually a different perspective. And it takes me back to a discussion that we had 2 or 3 meetings ago about digital connectivity and what we were doing about that. And I was hoping that we would rather have a programme of digital connectivity for older people. I think that there is a need and a hunger out there for it, for training, for accessibility to digital connectivity. And I think that that might be of great value across the board, not just in relation to this item.
I think there's also a question of who and where that's best done, whether that's us or somebody else. I don't know in the replies if that could be also commented upon. And Councillor Bird, please.
Thank you, Chair. I think we've all noticed that over the last couple of years, we now go knocking on doors to see a lot of our elderly residents that we hadn't seen for a while, how much they deteriorated, because they're not having the human contact with people, they're not going out, and I worry about that. And some don't use computers, some do, as we've just said. But then we've got the people who can't read, all right. And then you knock on their door and they're having problems getting food, having to ask neighbours. They're in a right state, so they can't have meetings by the computer. They need to be face to face, because we can't go in their house, so we don't know what it's like, but you can see the state of them. So I'd like to know if those areas are checked. I know I've referred a few people to the service. And going on about the handyman, the gardener and everything like that, let's put them in our magazines. Each ward probably has a magazine that goes round once a month or quarterly. Let's put all that information in there. And of course, like the City Council, we have Open Door and Cambridge Matters. So it's probably is advertised in there, which goes in nearly every door. Perhaps the other areas, South Cambs, Finland, and that could think of that idea to do that, because I do know the handyman service is a very good service, but it's people knowing about it, and that's what we have to keep pushing And also suffering are the disabled, because they've been stuck at home. They daren't go out. They've got this fear. So we're coming into the mental health part there. So they haven't been out. And now Tesco's are not, or whoever, whichever supermarket, and are not making them priority anymore. So they're having to wait longer for food deliveries and that. So I think we need to keep an eye on that as well. Just a few points, Chair.
Good feedback. Thank you very much. Just from me, everybody said handyman. It's handy person, according to the report. And there's lots of women included who are very good at doing things, including in my house, I can tell you. And shame on South Cambridgeshire District Council who call it a handyman service. I hope all South Cambridgeshire colleagues will change that name. The other arguably more serious point I'd want to make, this idea of breaking up the rest of the contracts into 3 lots. I think we do need to reflect on how we make it as local as possible in the context of the council's decentralisation plans and what we're trying to do on Care Together. And I don't think the default position can be we just break it up into district by district. So I'm a little worried by that, I have to say. I don't see that as being a reason not to pass this recommendation in this case, but I just signal that from this meeting. And I think we should also say everything I know about age concern in Cambridgeshire is good. And they might perceive this as breaking up their aspect of the service. We have to have a tendering process, we all know that. But, I again would want to place on record, there's nothing that we know as an authority, or I personally know, that suggests that anything other than the age concern has provided an excellent service in the areas of the county that they're responsible for, and they shouldn't read this decision as being anything there, and they're invited to apply just as much as everyone else. Did I want to add anything? Sorry. Age Concern UK, I'm being told. They said they get that right in South Cambridgeshire. No, those are the two. The final one is just about having a holistic view of the service. The Vice Chair and I often talk about this, but we don't always take decisions with a proper context. And I don't mean she and I mean us as a council, take decisions with a proper context of how one service impacts upon another. We had a whole issue about homelessness last time, we got a new one this time, and there wasn't any cross-referencing between that. And we are asking officers to present reports that do put any decisions about service into the context of other services that we provide. A good example of that is the later report about extra care, which has a really good appendix that shows how it fits into other things, both within the authority and outside it, which is great, by the way, and thank you. But if we can try and do that in other reports, that would be great. Quite a lot to answer there, Lisa.
I do my best. So in terms of performance numbers, I don't think that necessarily reflects the number of people who are using the service. And one of the things that we need to look at with the new contract is the monitoring returns and template, which have been in place for quite a while, so that it better reflects what the service is actually delivering. There is high demand for the service across all areas, and they try not to run a waiting list, but sometimes people may have to wait for an assessment. So we are confident that the service is being well utilised. As I say, I think we can do better in showing actually what it's delivering in terms of the outcomes for the people. So, what difference it's making for the spend the county council are investing. In terms of trying to broaden out advertising, we are aware that there are some areas where the service is not known in some of the smaller rural areas, but then there is a balance around promoting it further and whether or not there would be capacity to pick up the extra influx of people applying for support. So we are quite aware that that needs to be balanced quite carefully as well. In terms of the comments around virtual support, we are very clear that this would be a blend. We're not looking to make this a virtual only service. There would still be a mixture of face-to-face visiting, but also the option of some virtual support, and that may be or is more likely to be where someone's already established with the service and something can be done via a phone call, or maybe through assistive technology somehow, just to cover off a conversation or an action that's maybe being delivered for that individual. In terms of the digital connectivity, it's something that we want the new providers to be involved in and to promote. And we have actually also tried to make links between our library services programme and these services. So it's very much about them trying to get involved in what's already out there rather than creating another programme to work through. In terms of the economic equality, we appreciate the moment that those values have been set based on current demand for the service across the areas, and the intention is to monitor and look at that and to understand more information around the demographic elements as the contract progresses. But I'm sure you would understand why we can't just immediately start moving funds across when we've got existing customers within those services as well. So we're also very mindful that there are people receiving a service at present. We've obviously set out the rationale for our recommending that we continue the partnering arrangement with the 2 district councils, but obviously if further information is required, that could be provided. We have had our pensions people have produced reports for us, have set out levels of liability and challenge in terms of a new provider accessing the pension service, and that's what some of those figures are based upon. I hope I've covered everything.
That's fine. Just for people in the room and people watching online, I'm sorry, I've closed this debate. You were interrupted once or twice in that presentation through lack of connectivity, but I took the judgment that we were hearing 80% of what you were saying, and it was beneficial for that to happen. So I just placed that on record. Is it a point of order or contribution to the debate? We're 45 minutes behind time, so I'm not going to take that. Yes, I'm closing down debate, that's right. We haven't heard anyone that has argued against this. So the recommendation is that we approve the recommissioning of the Older Persons Visiting Support Service for a contract period of 5 years and a total value of £4,537,895, and that we be agreed to delegate responsibility to award the contract to the Executive Director of People and Communities. Is it a point of order?
Just to say I will be abstaining because I feel that I've been shut down. I've not been able to, I've not been able to get clarity.
You're not being called. If there's a point of order, I'll take it, but there isn't a point of order. Right, so we now move to those recommendations. I've not heard anyone argue against. I think we are going to have at least one abstention. Do anyone want me to put this to the vote?
Yes. Could I ask a question?
No, I've got to be fair to both sides. I've closed the debate. I've closed the debate. With 45 minutes behind time, everyone has had a chance to ask a question.
So basically, it's more about time than getting a proper debate.
You've 4 times come in without being called, and I think respect to our rules of procedure is really important. I've heard a call to have a vote. Those in favour of the recommendations, please show. 6, 7, 8, 9. Those against, please show. Those abstaining, please show. I see 2 hands. Can I just check? 9-2, 9-4, 2 abstentions, none against. Yeah. Okay, 9-4, 3 abstentions, none against. That is passed. We now move to item 7, the procurement of the county-wide floating support service to prevent homelessness. That's on page, the report is on pages 97 to 114 of the agenda pack. And Lisa Sparks is staying with us, and we'll hope we'll hear more than 80% of what you've got to say to present this report, Lisa.
Okay, I do apologise. My internet does not seem to like Zoom particularly well. I'm not sure why. Okay, so this is a paper regarding the re-procurement of the current county-wide floating support service that is delivered for working age adults. So the aim of the service is to prevent people from coming into the homelessness arena, so homelessness prevention, but working with people well in advance of that happening to ensure that whatever the issues are that are leading them down that route, that they can be addressed and they can access ongoing support. Of homelessness are well documented, and by delivering this service we aim to mitigate the need for people to go into crisis or higher care services.
Lisa, I'm sorry to interrupt you. I'm really sorry. It's been suggested to me that you turn your camera off and that maybe that will improve the sound. Would you mind trying that, please?
Of course, I will.
And then please continue.
Right, okay. Hopefully that's a bit better. Yeah, so as I say, the service is around reducing the risk of homelessness for people, and in turn means that they do not they're not affected by the longer term aspects of homelessness. So things like mental health, issues around family breakdown that come from that. And that in turn helps us to prevent people from going into crisis or higher care services. The service does also include a mental health component to the support that's funded specifically to support people who generally would not be eligible for statutory mental health services. We are seeking for the new service to deliver support both face-to-face and virtually, and that's taking on board the learning from the COVID pandemic, where a number of customers actually expressed a preference for being able to have virtual support sessions because it fitted better with their lifestyle, and they found it was easier to manage around their lives. We are recommending that this service is contracted for a period of 5 years and a total value of 4.8 million. And again, to agree to delegate responsibility to award the contract to the Executive Director of People and Communities. Does anyone have any questions? Hopefully that's better with the camera off.
It was indeed, and thank you very much.
Thank you.
Let's now have the debate. Councillor Slatter, please.
Yes, I'm well aware of the ways in which we refer people to services in Cambridge City. What I don't know is how it works in the rest of the county. And I am concerned that to know how the referrals work when you've got such the floating system. It obviously has done a lot of good for a lot of people, but we're back to making sure that members know how to advertise it and how to enable people to access it. So that's the simple question, really. We haven't got numbers this time to look at, so they may, other than geographically, but I would like to know if it's reaching the more out of the way places where there may well be less support for people in their need.
Thank you. Councillor Ambrose Smith, please.
Thank you, Chair. Regarding the length of the contract, it's a 5-year contract, but it's got break clauses in it that 3 plus 1 plus 1. I think that needs to be expanded upon, please, if we could. Thank you, Chair.
Thank you. Next, we have Councillor Van der Ven.
Thanks. Just a small point on the client outcomes table. It feels quite corporate, and there's an outcome there, be healthy. I just wonder if we could call it improve health or something like that, because these are actually quite very serious circumstances, and if we can improve someone's health, that's a good outcome. But just seems more realistic. Thanks.
Thank you. Councillor Wilson, please.
Thank you, Chair. And this is now the second paper where we've got the actual contract value, both the annual value and the 5-year value. I thought if we were considering the value of contracts, we should do that sort of thing in the private session. The second question is, it talks about having a small amount of Peterborough funding within this contract. So I'd like to know a bit more about why we are doing that and how that's going to be managed. I thought increasingly we were saying we wanted to be separate from Peterborough and not to have joint working.
That's a big point in the last second. I'll say a couple of things. One is just to reiterate what I said about the holistic view. You know, everything that I've read in this report and heard suggests this is an excellent service that we will want to support. But if it's difficult for us to join up the dots between the different service provision, then it's very, very difficult for people that we represent. And so we need to find ways of better understanding that. Maybe not an easy answer. On that point about Peterborough, just to place on record, it is the position of the joint administration that we're looking to more greatly differentiate services with Peterborough. That will inevitably over time mean more contracts are Cambridgeshire and Peterborough separately rather than together. But we've also been very clear that we don't want to stop shared services with Peterborough. We want the best of both worlds, to take the advantages of shared services where they exist, but also to pursue separate approaches where genuinely Cambridgeshire wants to go in a different direction from Peterborough. And we see the value in working with our officers towards that. We'll hear the answer to the question on why there's some advantage in this contract, and also how the different financial contributions are worked out and fair, which are obviously important questions to answer. But I just, because of the way Councillor Wilson put it, no criticism or disrespect to you, I thought I'd better put that on the record. So Lisa.
Okay, so in terms of referrals, this service actually has a portal that anyone can refer to online. They can also phone for referrals for those people who can't access online systems. Those referrals go straight through and are processed by the service provider. Although it is a county-wide service, they do have distinct teams based around the county to ensure that they can deliver effectively to areas without obviously people travelling round and round more miles than they need to, and to ensure that each team has a base, and so you have localities there and people to cover for things like absences. In terms of the contract 3+1+1, generally if we offer a longer term contract, we will always have break clauses in there, both for us and for the provider, but it also enables us to look at the contract and ensure it's delivering what we require, and if our needs have changed, it enables us to look at an alternative. But the actual length of contract is also discussed with our procurement and legal colleagues as well, so we follow their advice on that. The comment around the Be Healthy heading I've noted. In terms of the Peterborough funding, Peterborough are essentially providing the same service, or P3 are providing the same service for Peterborough. It's a much smaller service. Peterborough provide the funding for that, and we have a delegation agreement in place with Peterborough governing their funding and the element of service that is delivered. Essentially, it provides economies of scale because we can have the same provider doing the same job across both areas, and it also allows for sort of sharing of staff teams and management. I hope that's covered all the questions.
Thank you very much. I don't know if Will can answer this, but Councillor Wilson's point about whether we really should be putting these figures in the public domain, and this applies to every report, doesn't it? It's not specific to this report. Could Will just answer that, please?
Yes, I think that we're comfortable with doing that, and I think as part of being clear about the levels of spend and being transparent about that, I think it's important that we do.
Fine, sorry, I paused, not because of anything else other than I'm looking for the note about what happens next. So thank you for that answer. Thank you for that debate. Thank you to you, Lisa. We now have the recommendations, which are to approve the recommissioning of the county-wide floating support service for adults with support needs for a contract period of 5 years at a total value of £4.8 million, and to agree to delegate responsibility to award the contract to the Executive Director of People and Communities. Anybody want to vote on this? Is it generally agreed? Yeah, I'm seeing nods on both sides. That is agreed. We now move to item 8, recommissioning of the Healthwatch grant. Lisa has drawn the lucky short straw this morning. So she gets to contribute 3 times running, and like the World Cup, you now keep the committee for forevermore. Lisa.
Thank you. Okay, so yes, the final paper is around the recommissioning of the Healthwatch service. So Healthwatch was established under the Care Act 2012. It does perform a statutory function in understanding needs and experiences of those using health and social care services and ensuring the views of the public shape services. All local Healthwatch organisations must comply with guidelines set out by Healthwatch England, so they are overseen and monitored. Healthwatch Cambridgeshire and Peterborough is a community interest company, and market testing shows there is no competition in Cambridgeshire to deliver this function outside of this organisation. They deliver priorities that are set out within an annual work plan. So again, there is oversight of what the organisation are doing and what the priorities are, and those obviously need to reflect what people want. And we're recommending this continues to be jointly delivered across the area, with Peterborough actually holding the contract in this case. So the recommendation is for a 5-year grant agreement with Healthwatch Cambridgeshire and Peterborough to deliver the statutory function and partnership boards across Cambridgeshire, and the committee's been asked to approve the spend for Cambridgeshire County Council of 1.7 million. Does anyone have any questions?
Anybody wish to contribute on this? Councillor Baird.
Thank you, Chair. Yeah, I found the organisation very good. Healthwatch, they send an email to, I get one, telling me what they're talking about, and if I want to join in, like the wheelchair services, and then you can put your thoughts about the service, if it's good, if it's bad, if it's terrible, you know. We do have problems where we don't get the equipment we need, but that's somewhere where disabled people can go and complain about it and know that something will be done. So I think this is a great organisation. They do a great job.
Anyone else? Councillor Wilson.
I think Healthwatch are doing a great job, and I fully support allocating a grant to them. I'm still confused by the joint administration's proposals to try and split out with Peterborough City Council wherever possible, particularly in this instance where we're saying the grant is being held by Peterborough for 5 years potentially. That's an awful long time, and it will take us beyond the next local elections.
Okay, anyone else? Just my own contribution. First of all, like Councillor Baird, I think Healthwatch play an absolutely invaluable role. We've had them here at this committee, and we'll have them again. They'll probably play a more important role as the ICS develops, because they'll be holding us increasingly to account in terms of our joint partnership working. So I want to say a big vote of thanks to the colleagues at Healthwatch. It was us, not this administration, the previous one, that required the 2 separate Healthwatches to combine about 3 years ago now. And one of the really stupid things that was an outcome is that they were denied contacts from the previous regime of separate Healthwatches. because of GDPR, and still to this day they can't contact people who were involved and interested in participating because we required them to be merged. And it does show that there can be unintended negative effects as well as positive effects. And even if that problem can be solved today, I would really like it, because there are people out there who could participate that are not, and it's very frustrating for the people in Healthwatch. But I also place on record, if we're doing some shared services with Peterborough, as we are, and we decide this is one, then clearly we're going to lead on some and they're going to lead on others, and that's just going to be normal. And the contract periods will, over the rolling period of this administration, inevitably pass the date of the next elections, in the same way that we've in this administration have inherited contracts from the past one. That's just the normal passing of time. But it clearly shows that this issue about how shared services and differentiation should come back to this committee at a certain point, so that we can have greater clarity on that. And this is something that we're discussing, the Vice Chair and myself, with our officers. So the concern and the question certainly has been noted. On the specific point about Healthwatch, did you want to come back at all, Lisa?
In terms of the Peterborough question? No,
just generally to any questions you've heard.
No, not really. I mean, I think it is worth pointing out that obviously Healthwatch also work within as they work within a health environment, the way that health services divide up don't necessarily stick clearly to county council landscapes as well. So, you know, in part of the north, we've got hospitals in Huntingdon and Peterborough that are connected. So actually having that service across both areas does help to facilitate some of that as well.
Lovely, thank you very much. The recommendations are A, to approve the approach for a 5-year grant agreement with Healthwatch, Cambridgeshire and Peterborough to deliver the statutory function and partnership boards across Cambridgeshire. And B, the committee is being asked to approve the spend for Cambridgeshire County Council of £1.8 million. Anyone want to vote on this? I'm not seeing that. The world isn't falling apart. Are these recommendations generally agreed? Yeah, again, I'm seeing nods on both sides. Thank you very much. They are. We now move to personalisation of care individuals. Let me just check the time. Yeah, we'll fit this in before break. We move to item 9, personalisation of care individual service funds tender proposal. It's page 149 to 200 of the agenda pack. And Graham Hodgson, Commissioning Lead for Care Together, will be joining us online, and I see him there. Graham.
Thank you, Chair. So this proposal does relate to one of the projects under the Care Together programme, and that is individual service funds. So the Care Act states that people can have a personal budget spent in a number of ways, one of which is a direct payment, where they take full control of how the money is spent. Another is a commissioned service provided by the council. And the third form of spending a personal budget is an individual service fund. And traditionally in Cambridgeshire, we haven't previously offered this option, but with a view to advancing along the personalisation agenda, increasing choice and flexibility for service users, we do wish to offer this offer. In order to do that, we need to work with some providers who are fully aware of how ISFs work and who will be able to offer high quality and safeguarding to people that they are supporting, and they will engage in frequent regular conversations with individuals about their personal outcomes that they wish to achieve in line with the care and support plan that's been prepared with a social worker. So this mechanism of a dynamic purchasing system will enable us to bring those organisations into the fold and put them in a position to support individuals who wish to have an individual service fund. One of the barriers to holding a direct payment that we've identified, particularly among older adults, is the burden of administration, the amount of bureaucracy involved in managing invoices and timesheets and arranging visits from different providers and so on. It is often too much for some people to want to cope with, and so their fallback position is to go for a commissioned service where they're somewhat passively receiving services rather than taking control of their life. And an individual service fund does give that flexibility, choice and control very personalized without That's why we're trying to move forward with this. I would stress that the value of the dynamic purchasing system over the 5-year period of 17.7 million does not represent any new spend or new investment. These are existing funds within the adult social care budget, which are currently being allocated through different mechanisms such as commission services, and we simply wish to ensure that some of that money is available for individual service funds, so it'd be transferred basically from one line of the budget to another. Some of the benefits of this, in addition to the personalisation, are actually efficiency in identifying some duplication of spend. So there may be situations where somebody has a visit scheduled from a support worker, but in fact, on one of those days, they may wish to go and engage in a day opportunity, a day activity, have an outing. And very often we're paying for those two kinds of support at once, which isn't efficient. So with a highly personalized individual service fund, though, that kind of duplication can be avoided, and therefore there's more efficiency. We also wish to stimulate the growth of community-based micro providers, and another one of the projects under Care Together is the Community Catalyst Care Micro Enterprise Development Scheme. And these care micro enterprises, who are basically sole traders operating within their own communities, even walking to work because of the very low distances involved, would be able to be paid through an individual service fund, as indeed they could be paid through a direct payment as well. So we are seeking approval to go out to tender for these ISF providers for a 5-year period with a total maximum value of spend within this framework of 17.7 million. And we'd also like to request approval of delegation of authority to award to the Executive Director of People and Communities.
Community Catalyst Micro Enterprise something. It's a great idea with another terrible jargon name, but it is a great idea, right? Supporting small businesses to be part of our social care landscape, closer to the people. But we've got to be better on names. We really have, because it puts people off. But thank you. That's a small point about your presentation, Graham. Let's now open this up to members who want to contribute. Anyone? Councillor Slater.
I don't think colleagues would expect a health committee to go by without me talking about toenails. I've resisted it so far, but it comes in now. No, seriously, I think I welcome this, but I've still got some misgivings. It's really helpful to know the context in national legislation and to know that we are addressing sort of the 11C. I'm a bit concerned that we really need a bit of a hybrid. Having done all this for my mother, but also having been as a nurse to people who are doing it all for themselves, I'm very aware that actually you could do with something almost in between. That sort of support which enables the family or the trusted partner to do some of that bureaucracy, but still have a little bit more say in it. Because I think once you've got an agency, you've got to have an appointment to review, and I'm sure they will be conscientiously reviewing and contacting, just like I got phoned up regarding my mother's care. But I often thought, how do other people cope if they haven't got the know-how or the energy? And things can change so quickly when you're looking after somebody who needs special care. So that would be one issue, whether there is any scope within what we're setting up to have support for families and informal carers to get more independence that goes with direct payments, but not carrying the whole responsibility. That's one thing. And certainly I hope that this service will be advertised in the brochure when it comes out again and on the website. The other thing I had, a small point, there is tremendous confusion about names in this world. Only yesterday I realised that Caring Together is an independent charity. Care Together, I believe, Mr. Hodgson, is part of the County Council. Is it? Yes. We're in trouble here. Cambridge City has got Care Together, and that covers things like the 65 plus service. I know there aren't that many words to choose from, and maybe catalysts are out anyway, judging by Mr. Chairman, but it is a tricky one. And finally, the smaller subsidiary care that people might need, like getting their toenails done, I think need to be on some sort of checklist that we know will cover the ground, and that the people we are involving have some expertise. Oh, and finally, I'm very glad to see you've kept 20% of the choosing criteria at the behest of the panel of users. And I'd quite like to know how you're putting those panels together. Thank you.
Okay. I felt the officers shudder when you suggested the name Care Together might be further reviewed. I promise you a huge amount of time and thought went into that. And there was a short list.
What I mean is, I think we just need to
need
to be clear as members, at least, which is which. Thank you.
Indeed. But can I just reassure everyone that's not going to be changed again? We now move to Councillor van der Ven.
Thanks very much. I guess, as has been alluded to, well, it's an exciting new era, I think we're coming into, but bearing in mind how personal this is, and there are really important personal choices here for people who need support, and also the interests that we hope to stimulate in communities for people to provide services. I would really love to see a plain English, totally jargon-free document, such as Healthwatch produces, and maybe we need Healthwatch's advice, both on all of the things we've talked about today, the ISF, and I shouldn't say ISF, what does that mean? So, if I were faced with this decision, I would feel intimidated by the complexity of the document. We got very familiar with these things, reading them at our council meetings, but we need these things in some kind of plain English. So a plea to put that on our agenda as we move forward. Thanks.
No other members. I'll make some comments. Oh, well, there is. I do apologise. Councillor Mark Howell has unfortunately found his way back in the room. Another joke, folks.
Thank you, Chairman.
Councillor Howell.
Thank you, Chairman. Chairman, I think this is excellent with regards to all forms of direct payments. We've not in Cambridgeshire been very good in the past for one reason or another. And I think this way now, especially with individual service funds as well, I suppose I'm very supportive of this, very supportive of this. The one thing I want to ask is, will we be looking at other counties in the surrounding area, which do have organisations that support and help people with regards to individual payments, or sorry, direct payments, and also ISFs. Will they be there? Will they be approaching them as well to look at if they'll be looking at this as well? Because this is something we've really got to knuckle down and get our particular clients to try and activate as much as possible, especially if possible those people who are, shall we say, younger, and therefore might be wanting to actually take on the responsibility, and rightly so, of their own care. Thank you, John.
Thank you very much. Excellent contribution. My own contribution. So firstly, to say this is indeed, as the report says, a priority for the new administration. We put this in the joint administration agreement, and it's in the priorities for this committee. And as Councillor Bird knows, disabled people's organisations have argued for a long time that there are disabled people, but also older people who are fully capable of doing the paperwork and all of that, and want to do so and want to run their own personal assistants, employ them, and the rest of it. And we do, as Councillor Howell correctly says, we underperform as a county. We can't be good at anything. That's not a criticism, but we're making a deliberate attempt here to get better at this, and for there to be, we know there's a latent demand out there for people to run their own packages and to receive direct payments, and we're trying to meet it. I'd also want to say that every social worker who works for the authority believes in giving the greatest control and choice to the users. It's not a saying that we don't do that anyway, and deliberately accused Debbie while saying that. But this is just one step beyond for some people who choose to make it. The issue that's interesting in this is the one picked up by Councillor Slatter, is that we're creating another bureaucracy, we're creating another agency here in terms of an individual service fund. And of course, it could be that it becomes as bureaucratic as sometimes our own services appear to be. I know we try that not to be the case. And the choice and control element might not be as real as we want it to be. And if you look at the diagram on page 163, it already is pretty mind-blowing to me, let alone a service user. I don't think there's an easy way around that, but I do think in the contracts, it's really, really important to emphasize that choice and control element. Otherwise, we're not really delivering. But I do take the point that this has been done by some other authorities. We've studied that, and it does work. So we're not doing this for any other reason than we believe it works. I do take that point from the report. I am nervous that care providers can apply for these contracts, because it seems to me there is a conflict of interest if you're working with a service user to help translate their needs, that if you're also providing services that you've got an interest in people using, because financially you benefit from it, that's difficult. And I, as I said to the officers beforehand, I'd really like the contracts to have a presumption against service providers doing this, because I don't believe in Chinese walls, I have to say. I hope that will be thought about. And like Councillor Howell, it's great that we're doing this in the area where Care Together has been piloted, but there are people who want to run their own care packages and have direct payments all over Cambridgeshire, aren't there? That's what the figures would suggest to us. So Graham, one question I do want to put to you is how quickly and how will we develop this for other areas as well? Graham.
Thank you very much, Chair. So to address Councillor Slatter's point, first of all, it's an excellent point about there needing to be a sort of halfway house in between the full control of the personal budget, which is represented by direct payment, and the commission package, which is more of a passive receipt of services. And that's exactly the space that the individual service funds are able to fill. Now, these trusted providers, the ISF providers, they will work very closely with the support circle of individuals, so family members, friends, voluntary organizations. Depending on the level of complexity of need of an individual, they will have more frequent or less frequent visits to the individual in their home, or if it's preferred, it can be done by telephone or some other mechanism. But basically, COVID permitting, it would be a personal visit. And that's when they will talk about the kind of support that is available and what local family members and so on can do. But then they would be looking to fill the gaps with other services provided in the local community in a very place-based way, as is the ethos of the Care Together programme. On the name, coming conveniently to the name Care Together, we obviously work very closely with Caring Together, with the charity, and we've discussed this name with them, and they're perfectly happy with that arrangement. The pilot, the early adopter site in East Cambs, where many of the projects of Care Together have been rolled out initially, has adopted the name Happy at Home, which is only going to be used in East Cambs. But as we roll this out county-wide, Care Together will become an increasingly recognised and familiar name, with no prejudice to the charity Caring Together, quite the opposite, because we're collaborating on many projects. When Councillor Slatter mentioned the issue of toenails, I'm afraid there was a connectivity issue. I didn't hear the full question, but I believe I'm able to address it, because obviously that kind of personal care, and I'm very aware of the lack of supply of this service in many communities where older people require that support. That would very much be contemplated amongst the needs and preferences of the individual, and on how their individual service fund could be spent. So whether it's a family member doing that for them, or a volunteer, or more likely a provider, that could be paid for or the provider would be paid for from the individual service fund. On co-production of the questions, so the point that Councillor Slatter is relating to in the document, in the proposal, is that we've asked people with lived experience of disability and service use to form a panel and come up with their own questions with no steer from the council whatsoever, that they would like the bidders on this tender to be asked. And not only have they come up with the questions, but once we get the bids in from providers, they will be analysing and evaluating those bids and scoring them with proper support from the council around scoring mechanisms and so on. And many of these individuals have been identified through Healthwatch that we've already heard about this morning. So we've gone to the partners that work very closely with service users. We've also approached current direct payment clients who are very familiar with and that's how the panel has been formed. Van Ven's point around plain English fact sheet, absolutely couldn't agree more. We are working, we have colleagues within the council who are experts at producing accessible documents with the easy read versions that you alluded to, Councillor Van der Ven. And also it should be remembered that social workers will be in clients' homes talking to them about their options, and they will be explaining how an individual service fund will work in very plain English in a way that the client can understand. But you're absolutely right about clarity and plain English in any public facing document. And that's why we have a public information group which discusses all of these issues before anything goes public. Councillor Howell's point about other counties and organisations in the region of the East of England who support people in this way. Yes, absolutely. There's a lot of regional collaboration going on through the ADAS network. There are also independent networks of independent brokerage services. And there are networks of commissioning managers like myself from other local authority areas who are already using individual service funds or beginning to implement them. Essex is an example, and North Hamptonshire as well. There are a number of local authorities in the region that are already using ISF, so there's a lot of exchange of information to address that. Councillor Howitt's point around bureaucracy, the whole point of this approach is to reduce the bureaucracy for the client, for the service user. So the language and the materials which are going to be used with individuals will be very, very simple, easy read versions very often where necessary. And a lot of the bureaucracy and the kind of financial calculation of insurance contributions and tax and all of those difficult things which do prove to be a challenge for direct payment clients in some instances, that burden will be taken on by the provider. So it's absolutely about making things easier for our service users. In terms of the conflict of interest with providers, we have two lots on the tender. One is for brokers of services who don't actually deliver any support themselves. And there's a lot of interest from organisations that are independent support brokers. And the other is from some home care providers who have a particular way of working, which is all about looking at the individual as a whole and improving outcomes for them. And because of some of the capacity issues that home care agencies are facing in terms of workforce and other pressures, they're actually hugely in favour of releasing clients who can become more independent, which is everybody's goal here, and because that frees up their staff to look after people who are less independent. And the tender is absolutely county-wide. So this tender isn't only for East Cambs once it's up and running for the 5-year duration of the dynamic purchasing system. As we roll out this approach through Care Together throughout the rest of the county, those providers on the DPS will be able to support people all over the county.
Thank you. The recommendations are to sorry, I have to go to the right point so I don't read it out wrong. A, approve to tender the ISF support service through a dynamic purchases system for 3.1 plus 1 years at a maximum total value of £17.7 million. And B, to approve delegation of authority to award this to the Executive Director of People and Communities following bidding, evaluation and moderation. Anyone want to vote on this? Are these recommendations agreed? Yeah. Yeah, I'm seeing nods on left and right, so they are indeed. It is now 12:10. We have a 10-minute break. Please be back here at 12:20 promptly. Thank you.
so they were up, they're behind schedule. So I'm up next after the break, so it's 4 minutes.
Welcome back, folks. So we now continue with the next item, which is the procurement of care and support in extra care. Is the report is on pages 201 to 210 of the agenda pack, and Lynn O'Brien, Commissioning Manager, will present the report. And Lynn, you're joining us online as well.
I am. Thank you very much, Chair. In Cambridgeshire, there are 18 extra care schemes, which are specialist housing schemes that have been specifically designed to maximise people's independence. People have the secure tenancy with the landlord and also access to the 24/7 on-site care service, which is contracted via Cambridgeshire County Council. People have, I suppose it's the best way of saying it is that people have got their own front door, maintaining their own independence, their health and well-being is maintained, and it delays or even reduces altogether the need for residential care. This paper is seeking authority to re-tender the care contracts in 6 extra care schemes, and this time for longer term contracts. The council believes that the benefit of the longer term contracts is it will enable providers to invest in training staff. So, for example, to support people more effectively who are living with dementia. And also there are lots more advances now in technology enabled care. And it will help the care providers to build longer term relationships with housing providers. And basically the county council's aim, if you like, is to probably open up the extra care schemes more effectively to the local community, and therefore that partnership working, if you like, between the landlord and between the care provider will be absolutely key to doing that. The paper is the recommendation on the paper is seeking to recommission the services for 10 years with the value of 11.75 million, and that's at 22-23 values, and also to delegate the award of the contracts to the Executive Director for People and Communities. Does anyone have any questions?
It's been said for me. Councillor Satter.
Seems to be just me. Very happy with this proposal. In the past, obviously, we had county council homes and they were sort of almost indefinitely commissioned. That didn't make them immune from criticism or hopefully from being held accountable, far from it. So I'm sure those of us who are these particular homes are in their own backyard will be aware of any problems. No home is going to be perfect. I think I've been to most of those when I was trying to find someone for my mum. But the attempt to make them community minded and having the community coming in and the residents going out is not an easy one, and I wouldn't like to judge the commissioned organisations if they find that's actually not something they can deliver, because depending on their own geographical setup and their own residents, increasingly we wait a lot longer before going into a residential care home, and it might well be that there isn't the same appetite for getting out and about and joining in, but there will be the friends of Bircham House and so on, hopefully doing their bit, and also maybe the facilities being available for exercise classes, even if the residents don't join in every time, as we know, they don't always, right? So that's one thing. I'm very happy with this. I would like to know what about the rest of the county. I assume this is just a tranche for mainly Cambridge City, but I see that certainly it's slipped in. So maybe I missed something in another meeting, or it's coming up at the next one in terms of renewing the contracts. But if this is testing the water on having longer contracts, I'm happy with that, because we all have a part to play then in making sure the standards are kept up. Thank you.
I think Melbourne and Sawston aren't part of Cambridge last time I checked, but I know Cambridge has great ambition. We next have...
Apologise, this wasn't a territorial imperative. It was just, I knew about those and they were near me.
Again, it was a light-hearted exchange, no more than that. Councillor Ambrose-Smith.
Thank you, Chair. Thank you. Regarding the contract, I've got or the paper, I've got no problems at all. But I asked a question on the previous item regarding the length of contract and why was there a contract break or the contract break clause to be put in. Here we've got a 10-year contract, which is excessive, but I understand the reasons why. But there's no breaks in any way. Please could you tell me why?
Good question. Councillor Corney.
Thank you. I think both of previous speakers have both sort of touched on what I was going to ask, really. I think Councillor Satter, obviously talking about the, it's very south of the county. I know there's other things a bit further down in, but interesting to know when other areas will be picked up on. That's touched on that anyway. And my colleague here just touched on the 10-year contract. I think 2.3. I think I was just going to ask it a slightly different way. I think it does actually say in 2.3 about a 5+5 with a standard 6-month break clause, but just making sure that is the first 10 years and not a 10-year contract, and then we look at this side. So it's a bit of clarity there, I think, because it's, whilst I understand the merit of doing a long contract, it is a very long while to be tied into something if we are stuck there. Thank you.
Thanks, and we do need clarity about that, so thank you. Councillor Murphy, please.
Yeah, I think having a longer contract obviously is really good for developing good partnership working. The risk here is in the pricing and controlling inflation, which is or allowing for inflation and a formula for inflationary increase, which is fair between the provider and the council. Could we have a little bit more explanation about what the thinking is behind that? Because I think that could be a really significant feature in the cost going forward.
Councillor van der Ven.
Thanks. Sorry for being late. The tea was an awful long way to walk. So I should declare an interest, I guess, in that Moorlands Court in Melbourne is in my division, and I do benefit from lots of learning there, and would like to thank CHS for always being willing to talk with me about general issues. I think it'd be really, on that note, there will no doubt be lots of really important and interesting concerns from our providers, which we need to hear and to encourage their questions to come to us. And no doubt the challenge of a strategic look forward over 10 years will encompass the issues of inflation and the workforce, the really dire situation in terms of workforce and many other pressures at this time. And so just really to acknowledge that and to encourage those concerns from our providers to be made to us. Thanks.
Lynn, would you like to answer those questions, please?
Yes, thank you.
I see we've got Joe there as well, so I guess you're for this item as well. You're both welcome to answer, although we are a bit short of time. Lynn.
Right, thank you very much, Chair. First of all, Councillor Slatter, when she's talking about, the facilities within the schemes, they do vary from scheme to scheme. Some schemes, I would say, are probably better located than others. But yes, I think there's a mix there, and people have got choice basically, and whether or not how much they want to get involved in activities either within the scheme or within sort of like the wider area. In terms of the contracts that are being tendered this time, it just so happens that the majority of them are in Cambridge and South Cambs. I've previously taken papers to committee for services elsewhere around Cambridgeshire, so they've all been retendered at one point or another. Councillor Ambrose, the question about the length of the contract. So the total length of the contract is 10 years, and we're suggesting that would be +5. With the standard 6-month break clause, thinking with the 5+5 would be it will be an opportune time probably to review the contract from the point of view of would the specification need tweaking at all. That there are going to be a lot of challenges, I think, for services in the next sort of 5 to 10 year period. So that was the thinking between the 5+5. Councillor Murphy, yes, you're correct. There is a risk, if you like, with the longer term contracts in for both parties, basically, in trying to arrive at a formula or a mechanism or a clause within the contract that adequately deals with the risk of inflation on these services. So all we can do is to ensure that we basically look at it from both parties. We can't just look at it from the perspective of the county council. We also have to look at it from the perspective of care providers and ensuring that when the services are retendered, that they are attractive to the market, but at a financially sustainable rate for the council as well. So that there's absolutely definitely a balance to be struck there. Councillor van der Ven, it's good to know that you're in touch with the services in your local area. Yes, there will be a dialogue with providers, and in terms of the longer term contracts, we recognise, if you like, the challenges within the care market at the moment. They're not necessarily quite as acute in extra care as they will be for home care providers, but they are still there anyway. And it's hoped that the longer term contracts will provide more security, because these are services that actually the council wants for the longer term, because they are certainly much more cost effective for the county council, enabling people to live independently for longer. But as I say, we do need, the contracts actually will enable the providers to invest in their workforce as well, which we regard as being one of the key elements, if you like, to retaining staff moving forward. Hopefully I've addressed most of the points that were made.
And Joe, I don't want you there without having a chance to say something. Is there anything you'd like to add?
Oh, thank you. Just to add one small point to Lynn's point around the inflation formula and clause, one of the things that we've built into the services is an inflation calculation, if you like, that is index linked to, for example, CPI. So as we go forward with the development of the commissioning, we will build in a kind of index-linked inflation formula, and that enables us to be able to work collaboratively with providers to ensure that the uplift is ensures that the contract value remains sustainable. And then we work through our kind of annual business planning cycles to make sure that we have sufficient funds available to manage that risk.
Thank you. Other than just reminding everyone, it is Councillor Ambrose Smith. I got that wrong in my first meeting, and out of respect for him and everyone, let's get that right in future. On the substantive points, Dan, is that okay if we change recommendation A to say 5+5 rather than 10? Yeah. Okay, so, I think the points made by Councillor Ambrose Smith and Councillor Corney were correct. So I do propose that from the chair. Is that not the whole report, but just that amendment? Are people happy with that? Councillor Murphy?
I think I would prefer not, because 5+5 sounds to me like it's a different kind of thing. A 10-year contract with a break is a 10-year contract.
Look at Councillor Courtney and Councillor Ambrose Smith. If it's 10 years with a break, does that meet your concerns?
If I feel like we're probably splitting hairs a little bit. I think I just a 10-year. Somebody reading the 10-year contract could be quite concerned. They might not necessarily understand the merit in it, but at a glance, somebody could think we're signing up to 10-year contracts.
Let's take officer advice, Will.
Yeah, thank you, Chair. So what we're actually tendering is a 5+5 base contract, and so if we were to change the recommendation to 5+5, that would reflect more accurately
technical accuracy.
What we're doing.
Councillor Murphy, you are happy with that? So with that change on that amendment, can I see nods if you do agree? All right, anyone against that? No, they're not. On the substantive recommendations, which I need to read out. A, approves the general procurement approach and the overall value of £11.8 million based on 22-23 values over 10 years, over 5 + 5 years, we're now saying. B, tender the care and support in the following extra care schemes: Bertram House, Sawston, Dunstan Court, Cambridge, Moorlands Court, Melbourne, Poppy Fields, Ainsbury, St Neots, Richard Newcombe Court, Cambridge, Willowbank, Cambridge, and C, to delegate award of the contracts to the Executive Director for People and Communities for decision. Anybody want to vote on that? Are those recommendations agreed? Yeah, again, I see nods all around the table. Thank you very much. Thank you to the officers as well. We steam on to item 11, commissioning NHS health checks. The report is on page 211 to 222 of the agenda pack. And welcome to Val Thomas, Deputy Director of Public Health, who's at the back of the room and joining us here. Welcome.
Thank you. Thank you, Chair. Yes, this paper is asking for the committee's support for additional investment as a catch-up programme for NHS health checks. Probably central to this is the importance of NHS health checks to the prevention of cardiovascular disease. I think if you look at a few stats on CVD, it's the biggest contributor to inequalities in terms of life expectancy. We have 17,000 lives lost per year. So it is quite central to it. And it's really, I think, probably has being impacted by COVID, probably out of more than any of our services, public health services that we commission. And I think the impact then on the CVD risk factors is potentially immense. So we've seen increases in obesity, which is the most obvious example, but also we are uncertain about the situation around smoking. So a huge issue. And since writing this report, I've been doing some work with the ICS in terms of cardiovascular disease prevention strategy and looking at the data, NHS data. It just confirms what I've just said in terms of the fallout from COVID is going to be fairly immense. I think what is particular to NHS health checks is the pathway for delivery, essentially. We have an eligible population, but that data is owned by GP practices. The local authority commissions the actual delivery of the health check. Then the follow-up of the clinical follow-up and clinical management of the health check goes back to primary care. So it does call for a very joined up approach to how we address this shortfall of health checks. And I think I point out that all areas, and I think the paper does include some information about all areas have been affected by COVID and rates have fallen across the piece essentially. But that doesn't get away from that rates are low. In terms of the commissioning approach, I've discussed this at length with head of commissioning and both legal and commission legal to look at the possible option of the recommendation in the paper around GP federations to be considered to be fall under public contracts legislation. Unfortunately, both GP practices and GP federations, which are made up of the GP practices, do not, although they perform the same function as many NHS organisations that fall under those regulations, they are not legislated to fit into them. But the recommendation from legal and from head of procurement that providing that each individual contract with each federation is not above the threshold, that waivers would be the best approach going forward. I think also we would not want to do this catch-up programme as being we will commission additional activity. We'd also have planned quite a comprehensive campaign using social media and social marketing approaches. I think there's a lot of evidence to say that people probably still don't, not all people, but some people don't fully understand what a health check is and have certain reservations. So we do need to get that understanding out there in the population and understand more the barriers to people not taking up their invitations. And I think longer term, looking forward, this is for 1 year, and I think it will very much inform our thinking going forward, and certainly with the developments around the system and system-wide approaches of how we commission NHS health checks in the future. They are perhaps central, and certainly in terms of the thinking in the ICS and NHS has been central to meeting their targets around cardiovascular disease prevention as well.
Thank you very much indeed. And this is a really key decision. They're all key decisions, but this is a very key decision that will have pretty immediate impact if we agree it. Anyone else? Correction. Anyone like to come in? And Councillor Van der Ven.
Thanks very much for this paper. It's really good to have a sort of a bread and butter public health paper on our agenda today. I wanted to ask, make 2 points / questions. One is about the capacity to deliver these NHS, these health checks, given the enormous backlog that a number of GP surgeries, primary care is facing. And I wanted to make a specific plea, perhaps to, I think, is CCG estates the right place? I'm aware of discussions in one primary care network of making use of community hub space for delivering non-clinical services, including exactly this. So the opportunity is there to help lift the burden from GP practices and their premises, and to help roll out this really, really important service. But I understand that discussions around premises can be very complicated. And I think if we could, as a committee, help to facilitate that, that would be really, really useful. So perhaps I could take that up with you outside of the meeting. And the second point, maybe the point has been made about picking up cardiovascular disease, and a really useful point that came out of the most recent quarterly liaison meeting with Royal Papworth, which I'm sure is fine to share here, was about the accountability of the ICS as a system, as opposed to individual organizations within it, i.e. individual hospitals and health partners. And I think this is a prime example of how the ICS as a system is going to be accountable. So if the health checks are picking up cardiovascular disease, that has a direct link to the work of Royal Papworth. And there we have the connection between what's happening in our communities and what's happening at a very important regional national hospital. So just going back to the first point, we need to unlock the capacity actually to deliver these health checks in new ways. Thanks.
And if that point about community hubs could go in the minutes, please, that would be great. Councillor Slatter.
Yes, I was just seeing if Councillor Van der Ven was going to say my point, but I was just going to add to yours, and that is in another committee, the Cosmic Committee, we're looking into improving the use of mobile libraries out of library hours for the delivery of ICS, or integrated care services. And I think indeed that can be done in conjunction with Royal Papworth. I probably ought to say I'm a governor of Royal Papworth, and they are very ready to see how the high tech can go with the low tech. So the idea that you can have preventative health checks as well as follow-up health checks, and encouraging informal sort of non-medical arrangements for diet and exercise, and just encouragement, that all fits in very well with what we do as a county council. I know we've all got residents who've been able to benefit from these routine health checks, which might be happening in the library, might be happening in other community places. Let's make every opportunity, take advantage of every opportunity. Parish halls come to mind, and deliver those things and help people get back. Because I think not only are people missing out on the healthcare they would have had, but they're even more hesitant to trouble the doctor these days. But if there's somebody at the library offering to take your blood pressure and weigh you in a nice way, you are more likely to go ahead with that. I think there's a great hesitation. I feel it. I don't really like to bother the doctor these days. And I'm sure there's lots of people like that. So these health checks from us will be very useful.
Interesting dilemma. Councillor Daunton.
Thank you. Point of information, could you tell us a little bit more, please, about the lifestyle behaviour service? That's my first question. And my second question is to do with the incidence of health, that rather the details that are picked up on a health check. So it includes cardiovascular disease, diabetes, dementia, and I'm missing something out. Has the list remained constant over a long period? Is the list ever reviewed? would the list change? Would, for example, long COVID be added to the list?
No one else? My comment is I regard this as one of the most important decisions we're taking today. There'll be all these extra health checks in the next year, which will have a direct impact on people's health. And I think it shows that our public health team has thought very carefully about use of the reserve and come up with this as one of the ways that we can actually use it in a practical but very beneficial way. So thank you very much to the public health team for doing that. I think that question of people being reluctant to go to the doctors, the balancing argument is people trust the doctor with their health information and not necessarily others. And obviously our health team has thought carefully about the best way of doing this and think going to the doctors as the route. But where the doctors do it is completely fair. And I think that Councillor Van der Ven's point can be inconsistent with the decisions we're taking today. And also just note in the report that it says it will work alongside, as it's spontaneous is the word that you use, outreach. So you'll do other things in addition. I think that you can hear there's real support from the committee for that and to have that as an element of this. And I think Councillor Van der Ven's question about can the doctors really deliver on this? Will they have the capacity to do it, even if we're giving the resources, is a key question. I see that I've missed someone and a couple have added their names to the list, so I really apologise for that. I've got Councillor Bird, Councillor Ambrose-Smith and Councillor Hay. Councillor Bird.
Thank you, Chair. Just to say, I've been using this service for the last 3 months. They've been phoning me, checking on my diet, see how I am, blood pressure, everything, rather than me have to go to the hospital. So I just want to say it's a fantastic service and thank you very much. That's all I wanted to say, Chair.
Thank you very much. Councillor Ambrose-Smith, please.
Thank you, Chair. Thank you, Val. Thanks for the report. Just to a point of information for you, Littleport Leisure Centre is an open invitation for the GPs to work there. That is open for them and they've already started working. So it's another item to add to your list. Thank you.
Good example. Thank you. Councillor Hay, please.
Thank you, Chair. I just wanted to ask, how are the general public made aware that they are entitled to a health check every 5 years?
Okay, I've already put my point, so I won't repeat anything. Go back to Val, please.
Right, thank you. I think we're referring to a capacity to be able to deliver health checks in terms of the recommendation around GP federations. I think that's what they're set up to do, is to provide that additional capacity and to provide it in a more flexible way. And that sort of fits with what you were saying about delivering health checks in different parts of the community using libraries, for example, as was mentioned as well. I think that's part of the narrative that we've been having with them, that we know that there's some more hard to reach groups, and those are usually in the areas where we have high rates of CBD anyway. So I think that's approach which is endorsed fully, and it's the expectation among the GP federations that they don't just stick to going along to the practice, but actually diversifying. And in terms of, we already do commission that opportunistic health checks already from our lifestyle service. So they do offer it in libraries and community centres and a wide variety of venues. And alongside this alternative commission through the federations, we've also increased the commissioning of opportunistic health checks through our lifestyle service. So we offer in a mix, because I think the point was made that some people don't want to bother their GP practice and some people really trust their GP practice. So it's actually offering different opportunities to suit people. But I think there is a need to get more information out there about health checks. And I've been doing health checks for quite a while. And I'm still sort of surprised when people say, what's a health check? They do get invitations from their GP practices, but people get a lot of invitations, and sometimes they're not fully understood. So it's actually having that confidence to look at it and interrogate, yes, this would be helpful for me. And that's something I think this will be worked. I do think, and I've been working with Matthew and his team, the comms team, and how we can take this forward, and also take it forward in collaboration with the CCG stroke ICS, as well as they are also very concerned about increasing the uptake of health checks. Then there was a question about what our lifestyle services. This is one of our major commissions in the public health team. The service covers a whole range of services. We have individual health trainers that work with individuals, with families, around supporting them with their behaviours, referring them to appropriate means of support. We do weight management services across what we commission across the 3 levels of weight management service, from the less intensive to more, the whole sort of community groups, through to that very intensive, individualized, more of a treatment service. We have specialist health trainers that work around mental health and certain minority groups as well. We do the opportunistic health checks, so quite a range, and also, of course, stop smoking service as well. I don't know how I could leave those out. So the whole range of those behaviours which have the most impact on health outcomes. And in terms of the health check programme, as I said, they're already doing opportunistic health checks, but we want to extend their activity. So again, putting that, making as many opportunities as possible, and also I think probably in settings where people feel comfortable, and time. I think time is the element. I think time is always, perhaps, GP practices are incredibly busy places.
Thank you very much.
And
I'm sorry.
Entitled to health checks every 5 years. It's quite, they become aware of their entitlement by invitation from their GP practices, and that's something we have to improve on as well. And they're entitled if they've not already been diagnosed with any condition, so that is, they're not already under the care of their GP practice for a condition.
Thank you. Sorry for interrupting you there. We now come to the recommendations, which are A, to commission additional NHS health checks in 22-23 to address low levels of NHS health checks undertaken during the COVID-19 pandemic. B, to agree a budget of £1 million for the additional commissioning, of which £407,000 would come from public health reserve funds. C, the commissioning of 3 GP federations to deliver NHS health checks if all procurement criteria are met. And D, to increase commissioning activity on an opportunistic NHS health checks basis as part of the collaborative model with the GP federations. Anyone want to vote on this? Is this generally agreed? Yep, again, nods all around the room. Thanks very much. Really exciting initiative. Thank you, Val. We now move to Cambridge County Council's Learning Disability Frameworks. This report is at pages 223 to 230. Oliver Hayward, Assistant Director of Commissioning, is joining us. Can I just say, Oliver, and to the committee members, this is obviously a procedural report of something that should have been reported to committee and wasn't. I'll allow any questions that anyone wants, but can I suggest you introduce it very concisely? Oliver, please, 1 minute.
Certainly will. So this paper seeks to deal with 3 contracts which were tendered in 2018 for adults with learning disabilities, namely supported living services, residential services and day opportunity services. So whilst the contracts were tendered in line with the public contract regulations of 2015, there was an oversight which meant that a key decision was not taken, and by that I mean it did not get approval from the relevant service committee. Once this had been identified, which was at the start of this calendar year, we brought it to at the earliest opportunity to committee so it could receive ratification. And that is what I'm looking for today from committee, is ratification in line with the agenda.
Brilliantly concise, and the report is very clear about why the error happened and also why it won't happen again. Any members on this? Anyone want to vote on this? Are the recommendations? I have to read the recommendations, sorry. The recommendations are to consider and ratify the procurement of each framework detailed within the report. B, to consider and ratify the total contract values for each framework detailed within the report, paragraph 1.4. And C, to approve to tender and award future contracts up to the value specified under each framework is delegated to the Executive Director of People and Communities. Anyone want to vote? Are those recommendations generally agreed? Again, there are nods all around the room. Thank you very much. Thank you, Oliver. We now move to annual social care, annual review compliance. Oliver's joining us again, and his colleague Kirsten. The report is at pages 231 to 234 of the agenda pack. Oliver.
Thank you. Kirsten is the Assistant Director for Operations and is joining me to present on this one. The report.
We're really short of time, Oliver. So can I suggest we go straight to Kirsten then, please?
Sure.
Kirsten, are you hearing me? Maybe not. It seems not. I think Rhiannon's listening to this. Can you send her a message? Oliver, could you summarise the presentation in case we don't get through to Kirsten in time?
Yeah, not at all. No problem at all. This is looking for authority for the council to invest in clearing the backlog of annual reviews for adult social care service users, which have come about as a result of the pandemic, where social workers were not able to get out into the community to undertake the annual reviews as would have been expected. It is looking for authority up to a value of £975,000 to engage with an agency, a temporary agency service, to clear the backlog over a period of 9 months.
Okay, and what I would say, I think Kirsten's frozen and not hearing us, so sorry about that to her, if that could be passed on. What I take from this report is that we're being honest about the difficulties and the challenges, and we're dealing with them. Some of the backlog, I think, isn't COVID related, and some is, perhaps a large part is. But in any case, the officers have seen this, they've analysed it, they've come up with a solution, and I'm assured that they've looked at different providers, even though this isn't going through some of the normal commissioning process, that they've looked at different providers so that we can be assured that we're getting a provider that is both competent to do it, but also provides value for money. Any members who want to contribute? Yes, Councillor Ambrose-Smith.
Just to applaud the initiative, very good. Just point at, again, there's an item 5.8 where the monitoring officer hasn't made any comment about ratifying this particular item. So 5.8.
Okay, fair question. At the end, Oliver, please come back on 5.8 in that question. Anybody else? No, Oliver, could you reply to that point, please?
Yes, so the 9th of March, since and these papers before we had a response, we've subsequently had a confirming acceptance to this approach.
Councillor Ambrose-Smith has indicated he's happy with that answer. Kirsten, if you are hearing us, sorry that the internet's connection has proven too difficult for us this morning to hear from you, but thank you for your work on this. The recommendations are to approve the contract award to an external provider over 22-23 with a total value of up to £975,000, and B, to agree to delegate responsibility to award the contract to the Executive Director of People and Communities. Anyone want to vote on this? No? Are these recommendations generally agreed? Yes, I see nods again, both sides of the House. That is agreed. Thank you, Kirsten. Thank you, Oliver. We now move to Justine and our regular finance monitoring report. I hope Justine will magically appear on the screen, but in front of us she does. Hopefully we'll hear from her. The report is on pages 235 to 286 of the agenda pack. Justine, please.
Yeah, I'll be super quick for you. So this is, the standard report that I bring to you every time, and we are continuing to see the same trends that we've been seeing, that I've been reporting to you all year, in terms of an overall underspend, an overall lower number of clients in particularly in the older people area. That is meaning that we are spending less than we had forecast, and an overspend on the learning disability side, where we've seen more complex needs post-COVID and pressure on costs in particular. We know we've got market pressures. They are covered off in these numbers. So still looking at 8 million under for adults and health. Public health, 3 million under. A lot of that is because of the application of Contained Outbreak Management Fund grant funding for all the work that the Public Health Directorate have been diverted to rather than doing their business as usual work this year, as well as underspends on the demand-led services with GPs and the like. So we've talked about health checks. You've gone through that paper. I've set out for you in here what the position is on public health reserves, just so that you have the overall picture of what you've already agreed to and where we are now. So at the moment, we're overcommitted for this year, but we know that we are going to do a big transfer at year end. So the expected position come the 1st of April is that we'll have 1.9 million of excess reserves, which is why I'm absolutely happy for you to approve the health checks money. And we are already working, the Public Health Directorate are already working on options to bring back to this committee in the next meeting in July to look at how you could spend that money. And then just briefly, there is an addendum paper just to make sure that you as a committee are aware of the things that are going to Strategy and Resources Committee that relate to the budgets of this committee. So there are certain things that Strategy and Resources are the ones who have the delegation to make decisions on, like debt write-offs and reserves transfers. So there's a couple of things there just to make sure that you're aware of what's going on. And that's all I really need to say, but happy to take any questions.
Very good, Justine. Thank you as ever. Questions from or comments from members? I see none. What I would like to say, first of all, these are difficult and exceptional times, and I know you're watching carefully what happens on the finance, and I want to give full support and confidence for the work that's being done here, not just in our finance team, but by our senior officers in managing what is a very unpredictable situation. And I think you're managing it collectively, you're managing it extremely well, and I put full confidence in that. And secondly, in Councillor Bowden's absence, he's obviously been concerned about the health reserve, and so this again puts on paper what it is, why it's where it is, and also says very clearly we'll come back at the next meeting in July with some further proposals again. And I think by taking a bit longer to do it and making sure we've really got the money, we'll come up with quality proposals like the one we heard about health checks. So again, I express full confidence in that. The recommendation is that we review and comment on the relevant sections of the People and Communities and Public Health Finance Monitoring Report at the end of January 22, that we endorse for approval by Strategy and Resources Committee the use of £407,000 from Public Health Reserve to support additional work on health checks in 22-23, and 3, that we note that the decisions the Strategy and Resources Committee will be asked to approve that relate to budgets within the remit of the Adults and Health Committee. Anyone want to have a vote on that? No? Are those recommendations agreed? I just check the Conservative side are happy. Yes, they are. Thank you very much. That's agreed. Thank you, Justine. Nearly there, folks, and we are going to get a lunch break, which I'm sure people will be very happy about. Item 15 is the Adults and Health Committee Agenda Plan, page 77 to 80 of the pack. Members will note an updated version of the agenda plan was circulated ahead of the meeting. Dan, can you just highlight the changes just so people are clear?
Thank you, Chair. There's just one further addition I need to make members aware of, which is the addition to the July meeting for additional government funding for drug and alcohol services.
Okay, thank you for that. So are there any comments on the draft agenda plan? Councillor Ambrose Smith.
The reserve date for the 21st of April, can that be taken out now?
There, but it's not specific. We have a proposal. It's clearly up for the committee to decide, but we've got a proposal that we don't have the committee on the reserve date, the 21st of April, but we use it for a workshop. Let me just be clear about the content of that workshop. All right, it's on the key performance indicators. So remember, we've had 2 papers in the last 6 months on this. And we've pushed back the discussion on it because the government is going to announce a national framework for assessing adult and social care, and it seems short-sighted for us to lay down some indicators ourselves for adult social care, then find that completely different ones are set by the government. So assuming that the government's proposals are published by the 21st of April, that seems the right time to study that. It's not a decision-making issue, it's a workshop, but as we're going to be inspected for the quality of our work and possibly told we're outstanding and possibly say that we need to go to special measures, it seems pretty good that we actually spend some time studying it. And so that's the proposal of how we use the 21st of April. So I hope that answers the question, Councillor Ambrose-Smith, and it was a good question to put. We were going to come to it, but perhaps not in that level of detail. I will just take any further contributions on that. Councillor Wilson?
Thanks, Chair. I'm very happy to support a workshop on performance indicators, but I just wonder whether there are any papers from the July meeting that are going to be ready in April that we could consider after the workshop so that we won't rush through the July discussions.
Fair point, Councillor Wilson. What we would do if the government doesn't come out between now and the 21st of April, there's some discussion about. So I think please mark it at least provisionally in your diaries, and hopefully the government will bring that out. So Charlotte.
We're sort of what we're finding is we're getting sort of gradual leaks of information. So we may not have the final official line, but I think we'll have a good idea of what to expect by then. That's my hope. Otherwise, it's all getting very late, especially in terms of potential inspection in the next financial year.
On Councillor Wilson's point, the aim is not to have a meeting in April. It's the purdah period anyway. So I don't think that we would plan to deal with any of the July items earlier for that reason. Okay, I see no other hands. So the recommendations are to note and comment on the training plan. Have we done that? We have. It is 8.5 minutes past 1, which gives us 51.5 minutes to have our lunch. Intense session this morning, but some important decisions. Thank you to all the members. I know Councillor Bird won't be rejoining us after the lunchtime. I hope everyone else will be able to, and we'll see you promptly here, please, for 2 o'clock. Welcome back, everyone. We're at the Adults and Health Committee March 2022 meeting, and we're reconvening after lunch for the health scrutiny section of the meeting. Welcome back as well to those watching the live stream on the Council's YouTube channel. And we're joined in this section of meeting by our cooperative members, and I can see Jenny Gawthorpe from Cambridge City Council and Sarah Wilson from Huntingdonshire District Council. Jenny and Sarah, you're very welcome. And if you use the hand function, I'll be watching carefully to make sure that you fully negotiate, take part in the debate. And Sam is joining us as well. Welcome to Sam. And just a reminder and also an explanation for the new members that we have come to an agreement between the Children and Young People's Committee and the Adults and Health Committee that the spokes of the Children's and Young People's Committee will be invited here whenever we discuss health scrutiny issues that are relevant to children. And the truth is that's a lot of the time. You know, many of the issues we deal with a lot of the time. So welcome to Sam, and welcome again to Councillor Goodliffe, the chair of the committee, in order to take part, and we look forward to your participation this afternoon. I'm just going to check my note. Yeah, please, sorry.
Yeah, no, sorry to interrupt. Just to let you know, I have a commitment that I have to leave by 4 o'clock this afternoon, that was all. So if I'm packing my stuff up, I don't want to be rude.
That's fine. Thank you very much for telling us in advance. And just a reminder that we don't take votes in the health scrutiny section of the meeting, and so there's no issues about the members who are joining us virtually. What we do is we do careful note taking by Kate and by Democratic Services, and then the notes form the outcome of the meeting. As in all county council meetings, people feel free to film and photograph and tweet as long as you don't disrupt the meeting. And everyone, please make sure your mobile phones are switched off or silent and vibrate. And we are, of course, being live streamed, and a recording of the meeting will be available to view on the County Council's website. Just before I welcome our colleagues to talk about the Hinchinbrook Hospital redevelopment, there was a question this morning from Councillor Wilson that we said we would come back to with Kate. Is Kate with us?
Yes, I'm here. I'm here.
Could you magically appear on our screen, please, Kate?
I hope that works.
Yeah, great. Councillor Wilson, could you just quickly repeat your question for Kate's benefit?
Hi, Kate. In our actions of a previous meeting, we were told that NHS England had been chased at least 3 times about the provision of dental surgeons in the east of England. Are you able to give us an update on where we are in Cambridgeshire, please?
Yep, they've still been chased, I'm afraid. I do believe that we've had some recent correspondence with them to say that they will be responding shortly, but I do apologise on their behalf, but we haven't had that response to date. So I would expect it in the next week. I did explain that this would be something that you as a committee would want feedback on, and I also requested that they give us a timeline for how long it will take them to respond, and they've said this week, so I'm expecting it by tomorrow at the latest. Is it?
That's fine, Kate. I think it is right for the minutes, though, that we asked them to say that the committee is concerned about the speed of, or lack of speed of, response in relation to this. It's obviously not your fault or this authority's fault, but if the information's there tomorrow and we get it quickly, that's obviously optimal. But it's fair, I think, to say that it should have come by now, and that we express concern about that. Okay, we now move on to item 60A, Hinchinbrook Hospital site development proposals. the report was circulated as to separate from the agenda pack. We all had it by email and it is on the council website. Thank you very much indeed to Caroline Walker, Chief Executive of the North West Anglia NHS Foundation Trust, Nashir Khan, the Trust Chief Strategy and Transformation Officer, who are joining us. And we look forward to debating this report with you. I guess, Caroline, you're going to come first. Welcome.
Thank you, Chair, and thank you for inviting me to this committee. I'm here on my own today. Ursula is on annual leave, so she presented the paper and has written the paper with me. And thank you for inviting me. I do meet with members of this committee quarterly to update on other issues. Kate facilitates that, but it's good to be at the main meeting. So the meeting has seen the paper as presented. Apologies for its late circulation, but hopefully this gives you some context to the Hinchinbrook Hospital site, where we're at with the site, what our future plans are, and it's something that as a committee you can learn to understand with us and go through the journey of redevelopment with us on this site. Just to take people through the paper, since we've merged and became North West Anglia, we've done lots on the site to support clinical sustainability and clinical services, and lots to integrate our services between the Peterborough and the Hinchinbrook sites within that. But it's now timely and appropriate that we do invest in the fabric of the site and take the sustainability of the hospital into the future 30 years. The hospital is in need of significant redevelopment, as many hospitals are in the NHS. I've given you some background in the paper. I've given you the 3 phases to our redevelopment plans and taken you through that. We've delivered phase 1 of that redevelopment, remodelling our emergency department and ambulatory care units, secured funding for that. We are in the middle of building, and the building contract is in progress at the moment for the next phase of that redevelopment, which is our replacing our theatres, £30 million being spent on our theatres, 7 new theatres being built. And then the paper takes you through the 3rd phase. One thing I want to make clear to the committee is that this hospital was built by the same building methods and construction methods as 5 hospitals in the east of England. 5 hospitals that are in need of replacement because of a design defect to the roof of the hospital, was something called rack construction, concrete. So that's an additional factor that we're building into our plans, and the government, based on an evaluation of that defective roof construction, have asked all of the 5 hospitals to make plans to replace their entire building stock that has that same roof construction by the time 2035. So with that context, we're doing lots week in, week out to provide safe, secure surveying of the site to make sure that we're aware of the roofing issues, and we have lots of issues to prop up the roof and to investigate any changes to the roof construction. And while we're doing all of that, we do plan to redesign the whole site and get out of those buildings, something we'll gradually do over the next 5 to 10 years. We haven't secured funding for that 3rd phase of the redevelopment, but that's something that we will start to do over the coming months, and certainly something that's within the next year to secure that funding. We are working with the regional NHS I&E teams, who are our main sources of funding, and national people to secure the funding for this, and working within the remit that all new hospitals have to do to meet the specifications of new hospitals. So I guess I was wanting to share with the committee the plans to invest in this site, reassure people that we've done all we can to secure sustainable clinical services on this site and reconfigure over the last 5 years to support the Hinchinbrook Hospital site. And now it's timely for a hospital that's 39 years old and was built for a construction life cycle of 30 years. It's timely that we put our plans together to replace the whole hospital and build a hospital fit for the next 30 to 60 years for the population surrounding the hospital. The paper talks you through some of the case for that, shows you the nice pictures of the new theatre complex complex that is in build at the moment, and makes the main clinical case for why we're doing this. And as a committee, you'll know the significant housing development to the south of Huntingdon and the significant housing development to the north and to the south of Peterborough, that will secure population growth for this area for many years to come, and put an increase patient referral to the site. So we're doing this in conjunction with integrated care system partners, and planning across the whole of the health economy to do this. But the main thing we wanted to bring to the committee's attention was the kind of current progress and then the future progress of the redevelopment of the site. I'm happy to take questions on the paper and answer any other specifics around the current redevelopment parts or the future planned ones, in line with national requirements for building new hospitals. Thank you, Chair.
Thank you very much. And I would want to say that we very much value the quarterly liaison meetings that we have in private, to have the dialogue between us. We very much value that, and it's great to be able to say that in the full committee and to give great thanks and credit to you. Who would like to start off on this paper, please? Councillor Van der Ven.
Yeah, thank you very much for the paper. And as the chair said, our quarterly liaison meetings, which I've been lucky to attend, have given us a lot of good background on this paper and this project, among other things. I just wanted to ask, I'm looking at your site map and the proposed new care home and residential accommodation. The opportunity to do a lot of new things around health and care, I believe tie in, am I correct, with the independent living aspirations of what the county council is doing? And so I don't know if that's a fair question for you, but just to take this opportunity to bring those things together for a minute, because here we do have the plan of what it's all going to look like and how it's all going to fit together. Are there any considerations at this stage? I'm looking at your travel. You've got some principles here around access, site access, and I'm sure these are things that will come into play eventually when we're talking about independent living. So those principles will be for the whole site, obviously, won't they? So I'm sure there are some good discussions going on, or will be happening, and capturing things at an early stage is always the best way. So I just wanted to plug that in. And I'm not, I hope that's helpful.
Okay, it is, thank you. I'll come back on that. So the independent living or nursing home accommodation is something that would be completely in line with integrated neighbourhoods around geographies, in line with NHS long-term plan aspirations. So that's something different to what's currently on the site. That is something that we would want to look for as a longer term co-location on that site. And that's something that would definitely involve either independent providers or the local authority, moving some provision to that site in a step down way, that we step down to, we step down some of our patients who don't go home to independent living straight away to alternative facilities at the moment. But this would be about having something like that possibly on the site. There's certainly plenty of physical space to accommodate something like that. I think the second part of your question, Councillor, was about access to the site. It's something that we think long and hard about. This particular geography and access to the hospital site does sometimes fall foul to congestion and things, and everything we do, we have congestion and access to the site in mind for emergency vehicles that come to the site in an emergency and to attend our A&E, but also to secure proper access so that the impact on the community around the hospital isn't adversely affected. We currently only have one main access into the site for staff, patients, the public and ambulances, and that's something that we would want to change when we were building a hospital that was fit for the next 30 years. So we certainly will be talking to councillors, the council and the district councils about another access now that the new link road's in. That's changed some things, and as we as we redevelop the hospital, we of course have to keep the existing hospital going at the same time, because we won't be closing a hospital and opening a hospital after the rebuild. They'll all have to happen all together. So we will ultimately be designing something that will have a new main entrance or a different main entrance to the current one, while we do the building and then move from the old hospital to the new hospital over time. So it's something we've got to think about, something we don't have a solution to at the moment, but it's definitely on the list of things to resolve and consider as we redevelop the site. Thank you.
Thank you. For the remainder, Caroline, do you mind hearing all the questions and then answering at the end, if that's okay, and then I can get some more members in. Councillor Wilson is next.
We have two Councillor Wilsons. I'm going with this one, and then
Mr. Graham Wilson. I do apologise.
My question is about the concrete roof problems, Caroline. In 1.6, you referred to the £280 million-ish of service infrastructure, which is not sustainable. You also mentioned that there are 5 hospitals, I think you said, in the region which were built under this method. So that's over £1 billion worth of investment needed. Do we have any indication as to what government's views are on this and whether they're likely to come forward with improvements of that magnitude? Thank you.
Thank you. And just to prove your point, Graham, Councillor Sarah Wilson, please.
Councillor Graham Wilson has just asked virtually the same question that I was going to ask about having to bid for money when we have a hospital that is at the end of its life. It makes me feel nervous that we have to bid for this money, whereas it seems our right to provide a service to our residents. So same question. Thank you.
Same question, but you are unrelated. I just put down for the record, unless there's something I don't know. We now have Councillor Murphy, please.
Hi, thank you very much for this. It's very interesting presentation. What do you think are the biggest risks? It's quite a complex development, and you mentioned, continuing normal services alongside. So you've got continuing normal services, maybe project management, financial risk. I'm just really interested to see what you think the sort of priority or the kind of hierarchy of risk is.
Thank you. We now have Councillor Daunton, please.
Clearly what you're doing is improving the built estate. I'd really like to hear a little about the landscaping and the possibility for more open ground for patients.
From myself, you're obviously speaking to us today, but through us, you're speaking to the public. And when there's going to be such a major development like this of a service which is critical and loved and needed by all of the people that use it, would you have some words of reassurance that services will be continuous and accessible whilst such a major redevelopment is taking place? Caroline, please answer all those questions.
Thank you, Chair. I'll go through them in order then. So the paper does document the money that we've estimated, the 280 million, to temporarily address the roof problems. So one thing I want to stress to the committee is that we have been given access to government funding to do the temporary things, to survey the roof, to prop the roof up, to put some steel structures around propping the roof up. And we are expected to do that for the next 5 years to keep the integrity of the roof in place while we design the hospital and start our rebuild programme. So that amount of money is money that's been made available. I guess the point that I haven't specifically said in the paper, but I will say now, is that I don't think that's good value for money. What we want to do is to start replacing permanent buildings with new permanent buildings, rather than taking action to extend the life of the hospital that we know has not got a longer term life because of that roof defect. So We will put our plans together for the complete replacement. We don't believe it's good value for the public purse to keep investing in short-term solutions. We want a longer-term solution for the next 30 years. Councillor Wilson was right in saying that those 5 hospitals add up to a big amount of money. The government have announced 40 new hospitals under a hospital infrastructure programme. It's called HIP2, and they announced 40 new hospitals. Of those 5 hospitals, 3 of them are already on the list. So we're already in an approved hospital rebuild programme. Hinchinbrook and King's Lynn hospitals within the East of England are the 2 that are not on the list. So that's why we're saying that we haven't yet secured our funding approval for the complete rebuild. So that's what we spend a lot of our time working on, getting the permanent solution and the permanent rebuild figured out. So hopefully that covers that question. Bids for money was also the Councillor Wilson's thing. We are bidding for money. We've got secured money to do the temporary work, the annual work to survey, the annual work to prop up where we find deteriorations or derogations of the roof construction. But what we really need to do is have a successful bid for money for the complete hospital rebuild. And we've bid and we're waiting to find out. The government intend to announce 8 more hospitals on that 48, the 40 hospitals turning into 48 new hospitals that they plan to build. And we hope to be on that list that gets re-announced, but we haven't heard anything yet. Councillor Murphy asked about biggest risks. I will say that the biggest risk is operational delivery of services. We are not in the position of having a greenfield, brownfield site where we're building a new hospital and then we'll move our services to there. We will be operating all of the current services, including a full ED service, from the site while we are doing a phased redevelopment as well. So that's one of the, in itself, that is the biggest risk, because we have to have all of our clinical adjacencies. It might not be something that's obvious when you're not familiar with life inside a hospital other than as a patient, but we do have to have some departments that are really quite closely co-located, and they have to, the integrity of attachments to theatres, for EDs, etc., and things like that. So it is logistically very difficult to plan, and that's one of the biggest risks, keeping the operational running of the hospital in play while you are rebuilding the new hospital at the same time. And gradually, as we build new bits of the hospital and new wards and new wings and new theatre blocks, the challenge is to attach them to the existing services so that you still get that operational functionality. One thing's for sure is doing it that way does cost more money, but we've carefully got to plan how we do that to keep the patient services running. There are no intentions to stop any services on the site while we do the rebuilding. I can reassure councillors of that and the public. Councillor asked about landscaping. That's something that we do work hard on. Hinchinbrook is a very green site, closely located to the Hinchinbrook Park, and there's a nice environment around there. And we will work hard to make sure that that's there. One of the requirements is for us to rebuild the hospital in a carbon neutral way, meeting modern methods of construction, the government call it. So we were doing our best to limit the carbon footprint as we rebuild the hospital. One thing I will say about the Hinchinbrook Hospital site, though, is it's very generously supported by lots of volunteers who kindly maintain lots of the gardens, and inside the hospital there are lots of internal gardens that the public and volunteers maintain for us for the benefit of patients. So they might not be so obvious to people around and walking around the site and driving past the site, but inside the hospital and inside some of the gardens in courtyards and secluded gardens around walls, there's lots of space that patients can get to. And we've got sensory gardens and other gardens that are internal inside the building that are very well used by patients, and certainly some children as well, and some of the internal gardens that we've got. So we do have internal gardens and landscaped areas as well as the surrounding areas around the hospital that we will attempt to keep. And then the final question was about public reassurance, really. I think hopefully my answer to the operational impact is answers that question as well. We will be doing all we can to keep our services operational and effective during the period of the rebuild. There's no intention to stop doing anything or to close any departments during the period of rebuilding them. We think we've got architects who've designed the rebuild of the hospital in a phased way that allow us to do that, and we plan to stick to that. Ideally, we need to secure the funding as soon as we can to get the risk of the roof defect deteriorating further. But we will bring updates on that. It does feel nice on the site, actually. obviously got the new buildings of phase 1, and the fact that we've got builders on site is an inconvenience and a problem for us, but it does feel nice because it means we are starting our redevelopment, and that the redevelopment of the site has commenced. So that is good for patients and the staff as well. Thank you.
Thank you. And I am keen that our district members fully participate, and I didn't see Councillor Jenny Gawthorpe Wood. So it has to be short, Jenny, but please do add a question or a comment.
Okay, thank you. So when do you hear about the funding from the new hospitals programme? Do you have to make bids in a piecemeal way, phase by phase or part phase by part phase? Can you use any of the existing 250 million refurbishment money for the redevelopment, rather than just for the sorting out the concrete roofs? And are there any planning issues, like planning committee issues? Thank you.
Thank you.
Yes, please, Caroline.
Do you want me to answer? Sorry. We were told that we would hear about the extra 8 hospitals that we were hoping to be on that list by spring. So in government springs, that's not always clear, but we would expect to hear in the next couple of months. There's currently an external review going on by some building surveyor, construction experts by the government, reviewing all of those 5 hospitals to see how best we can all learn, because we're all designed the same. Kings Lynn, Suffolk, and ourselves, and James Paget, they're all exactly designed the same and have got the same construction defect. So we're all trying to redesign our hospitals the same to get the benefits out of how we redesign them. So we're expecting to hear in the next couple of months following this review that the Treasury are doing actually at the moment of how to best achieve value for money for the rebuild of those hospitals. And the money that we've been given each year to do the temporary solutions, we definitely can do some permanent building replacement on those, and that's definitely what we're planning to do. But we also have to do the annual surveying and the annual repair and the annual propping up of things as well. So we must do those things as well as try and use some of those to do some permanent buildings. And certainly the money that we've been given for the year that's just about to start, 22-23, we will use a chunk of the money that we've been given to build a new service wing, which is where we do our laundry and our sterile services and most of our logistics work, because that's one of the buildings that's got the most defects that we've found in the early surveys. So we definitely will be doing partial new buildings that will be permanent solutions with that money, but it's certainly not enough for us to do a lot of clinical building redesign. That needs to come with additional funding.
Thank you very much. Caroline, you're staying with us for the next item, but I do have to put to the committee the recommendation, which is that we note the update on the Hinchbrook Hospital redevelopment. Everyone happy with that? Yep, seeing nods all round. Indeed. So thank you very much for that. Thank you, Caroline, but please stay with us because we're now going on to item 16B, staff support of North West Anglia NHS Foundation Trust. The report again was circulated separately to the agenda document pack, but is on the council's website. Caroline, would you like to present the report, please?
Thank you, Chair. Presenting the report at 16B for you, then, which was in request to give the committee an update on workforce pressures and support programmes we've got in place to manage our staff-related issues. This is a key part of the quarterly liaison meetings that we do have with members of your committee. They have regularly throughout those meetings asked me to reassure them of staff welfare and the staff pressures within that. So it's definitely a real topic for us all. The paper takes you through the multiple issues that there are within staff and the appropriate actions that we have taken and the things we constantly do to help our staff cope with the pressures of working in the health service and working inside hospitals, particularly over the last 2 years. There's a focus on staff absence, which has been a feature throughout the pandemic, and the services that are affected by COVID-related absence and non-COVID-related absence within the paper are articulated. By way of context, I've taken you through the fact that we have over 7,000 substantive members of staff, and then over 800 members of bank workers who work on a flexible basis with us. And certainly we have definitely got lots of volunteers working with us as well over the sites. We have over 300 different roles in our organisation. So we have clinical and non-clinical staff and lots of different roles. So there's a multiple range of different issues within staffing. As we sit here today, staff absence is still an issue. So short-term staff absence due to illness is an issue that affects our service provision on a daily basis. And we are constantly doing all we can to support staff and help staff return to work. Today, as we sit here, staff absence is rising again, linked to community prevalence of COVID, and certainly the numbers of COVID patients inside our hospital slowly rising over the last week in line with the national picture as well. I think the paper takes you through the issues that we've done to support staff, the issues that are very real, the absence from our hospitals due to short-term sickness and absence are linked to COVID-related illness, but they're also linked to health and well-being. And that's the shift that we've seen gradually over the last 2 years, that more of our staff are absent from work linked to the stress-related health and well-being issues, rather than COVID-related issues specifically, or COVID infection-related issues. So we do all we can on a daily basis to balance our service needs with the absence rate. We move our staff around, we flex our workforce, and we cover those absences, be they short-term absences or more medium-term absences, by that flexible workforce of bank, and flexibly asking our own staff to work extra hours, which does indeed take its toll on the workforce as well. We've done lots during the last 2 years to support our staff, more than we ever have done before. As a health service, we do lots to support staff and support health and well-being, but we've done some exceptional things, as well as our staff doing exceptional things to care for our patients and each other. We've done some exceptional things to support staff as well, and the paper takes you through some of those. One thing I will highlight to the committee, which is possibly something that's not necessarily understood by the public, is the flexibility that our staff demonstrate. So whilst providing services to patients and delivering care, they provide great flexibility, and redeployment is a feature of what inside our hospitals on a regular basis. When we have staff absences and when we have services that we change linked to COVID pressures or surging COVID pressures, for example, at times we expand our intensive care department by adding more and more beds to that department, and then we ask people from other areas inside the hospital to go and help staff those extra beds to cope with the pressures of COVID patients, etc. So redeployment of staff on a daily basis around different parts of the hospital is something that's happened amazingly well during the pandemic, and our staff have been extremely flexible, but that takes its toll on staff. One thing I want to make clear to this committee is that when our staff are doing all they can to keep patients safe and to care for patients, they demonstrate a lot of flexibility. But imagine coming into work every day for your shift and not really knowing which ward area, or whether you're going to go and be asked to work in a different area that you're not used to working in clinically. It brings with it worries for staff, and I do have to commend our staff for meeting that challenge and coping with that pressure that we put on them. So the paper articulates the range of absence levels that we've had. As I sit here today, our absence is something like 4.7%, which is 450 members of staff absent from work today, linked to sickness, either COVID related sickness or other related sickness, non-COVID related. The paper takes you through the range of things that we do to support our staff. We also have gaps within our staffing needs linked to vacancies, which is something that's a consistent across most hospitals, and our vacancy rates are below average for most hospitals in the east of England, but they still are a challenge for us, and we do lots of work and have lots of investment in recruiting new members of staff across all staff categories, and a lot of that includes international recruitment as well, and we do work across different geographies to support that international endeavour and support our staff who do come from overseas to work in our hospitals, particularly around the Hinton site. We've got an extremely well-connected Philippine nurse population that provide a fantastic global workforce inside the hospital. So there are lots of issues that we've still got to get more traction on within the hospital, permanent recruitment being a good place to work, and retention, a good place where people don't want to leave the trust and are happy to stay in the organisation, a feature within that. We want them to come and work in a workforce where they feel supported and feel supported in their jobs, and to raise any issues that they have with their employment. So I think the paper takes you through that whole range of issues that are about workforce pressures. They come under a multiple range of headings. We have staff surveys and ways for staff to give us feedback on the pressures that they're facing. And certainly at the moment, work-based stress and pressure, I'll stop short of using the word burnout, but there are lots of members of staff who after 2 years worth of the pressures of the service provision during the pandemic, have been struggling more than they might normally have done. Just to reassure everybody that we do support those members of staff through a robust occupational health process and some health and wellbeing support through various options for them to access as they want to. So I'll stop there and I'll be happy to take any questions on the content of the paper or issues that have been raised. Thank you, Chair.
Thank you very much. And again, we'll do all the questions together and ask you to respond at the end, if I may. I've got Councillor Corney first, please.
Thank you. And my question was going to be two parts of it, was about vacancies, and you actually answered it right towards the end. One of them right towards the end there. I guess the second part was just intrigued to know of the. So we sort of say 9% this year, 5% last year vacancies. You said in the presentation that there's, I think it was just over 300 different roles within the hospital. Just intrigued to know of those vacancies, what the spread is over those roles, because obviously some of those roles are going to be a lot harder to fill because of the amount of training it's going to have to go into to fill them. So just be interested to know how that spread works over those vacancies. You know, that correlation there. So the first part was you answered, which was I was going to ask how we was faring up with other hospitals, and you said we're probably a little bit below average there. So you answered that anyway. Perfect. Thank you.
Thank you very much. Councillor Daunton, please.
Yes, thank you. I have two questions. One concerning the referrals to occupational service, staff referrals to the occupational service. Obviously, that service has been receiving an increasing number of referrals. Is there any possibility of using an out-of-house service as a backup, as an independent backup? That's one question. And my second question is about recruitment. You've managed to recruit 52 nurses who are about to join the trust. How long does it take from the point of recruitment to they're actually getting to work on the wards?
Anyone else? One from me then, please. In terms of your bank workers, you know, I guess the problem at the moment is people are working over long hours. For good reasons, I know, but I guess that's the problem. But are those? Is that flexibility fair to them as employees? Are they on 0 hours contracts? And what thoughts has the trust got about trying to regularise the employment of those workers in a way that is mutually beneficial both to the trust and the workers themselves? And as you know, Caroline, from discussions in the ICS, we're keen to look at some of the issues about recruitment bottlenecks jointly with our health partners. Could you comment on that? And I think probably the work that needs to happen is at our end, not yours. So I fully acknowledge that, but it's good to raise the issue again and hear your response to it. Finally, I should have said back to the bank workers, you'll also know that we as an authority are committed to introducing the real living wage for all our staff, but also all our contracted staff or staff for our contractors. That does have a financial burden associated with it. We know that, but do you have any aspirations in that direction, and where we do things jointly, how would you feel about moving in that direction? Caroline.
Thank you, Chair. Right, starting at the top, I'm glad I answered the question about vacancies. Whilst I mentioned that we were just below average on the level of vacancy, it's still an issue for us. I always say that if I had a magic wand, I would use my wish to have all of the people I needed and no vacant posts and nobody ever leave the trust. So that is my wish for the hospitals. Training more nurses, doctors and other professions is key to this as well. International recruitment is pretty key, but as a global health service, training more people and encouraging more people to come into training in their early years is definitely something to do. The posts and our vacancies are spread across all areas, and certainly post-COVID, some of our vacancies, so I would say our biggest vacancies aren't nurses necessarily across the board, but in our ED and in our intensive care areas, that's where we've got hotspots, and so certain areas that are under pressure certainly have a higher turnover than others. So whilst across the board there's a spread of where the vacant posts are, we have quite a few vacancies in our therapies, allied health professionals. So we tend to not have many vacancies in our medical workforce. There's a few specialties that we struggle to recruit, be it stroke specialists or certain different specialists, cardiology specialists, but it's not necessarily across the medical workforce we have the vacancies. One of them, maybe the biggest areas that worries me at the moment, is admin and clerical vacancies. We've never had admin and very clerical vacancies as a trust before to a large extent, but since COVID we find that other employers offering different salary packages are able to take some of our staff, and turnover has been quite high in admin and clerical posts. I think people forget that admin and clerical posts inside our hospitals play a very important role in supporting clinical services, and certainly a big role in booking patients and bringing patients in for interviews and appointments and their patient care. So that's roughly where all the vacancies are. The biggest by far part of our workforce is nurses. So the number in absolute terms is bigger for nurse vacancies, but as a percentage, it's not the biggest area within that. Admin and clerical is probably our biggest area of percentage-wise. The next question was about occupational health services. So referrals to our occupational health service have increased. That's definitely the case. We do have a good occupational health service, and we do have good access to senior nurse opinion in that and medical opinion within that to support staff. We haven't as yet had to consider outside service and doing that service to an outside company, and certainly over the years we've provided the service outside to other organisations as well, because we've had such a good service. The impact at the moment of the increased referrals is that there's a slightly longer wait to see the service or get access to the service within that, but it's something that we think we can cope with, and we do have the flexibility for the staff that are in the department to flex up and do extra time on a voluntary basis as well. So at the moment it's something that we think we're in control of, and that our staff are getting the support they want. But we would consider flexing that service should we think we need it. But we complement it with other support services from the Mental Health Services Trust as well in the county, which is where the bigger need is for onward referral to specialist support. Recruitment, you picked up there at the 52 international or 52 nurses that are starting over the next few months. Time to recruit is different, and even nurses that have trained with us and trained locally in things don't go straight into the numbers on the first day that they start. They have a period called supernumerary period, and that ranges from 6 weeks to 8 weeks to 12 weeks, so where they're not counted and they're supernumerary to the nurses on the wards. So that gets them to integrate into the workforce, get the hang of doing things, get themselves trained, and certainly with international nurses that's a few more weeks longer than UK trained nurses, just to get them to the hang of the nursing standards and the national standards within the UK nursing practice. So it's something that is an issue, but it's something that we have robust plans in place to make sure that. So the answer there is that on day one, a new nurse starting in the organisation doesn't immediately have full responsibility in any area. They have a supernumerary period, and that's pretty standard for most hospitals, not just about our hospitals. Bank workers, I will start by saying that all of the staff inside our hospitals and those that are employed through subcontractors as well are on the national living wage. That was something that we built into all of the contracts we had with our staff and with our subcontractors for operational services. So that isn't something that would be an issue as we go into joint working and joint roles in and out of hospitals and with other members of the integrated care system. Bank staff are 0 hours contracted staff. And they're members of staff who choose to work on the bank. So I can categorically say that of those members of staff on the bank, if any of them wanted to have permanent positions, we would probably make permanent positions available to them, and we would probably have enough vacant positions for them to take up those vacant positions. Lots of them don't want to work full-time commitment, and possibly some of them want to work 3 months at a time and then not work. And some of them are definitely retired members of staff who don't want to do full-time jobs or don't want to work regular patterns, but they're happy to come and work periodically and do ad hoc shifts. So our bank workforce is made up of different members of staff who are on the bank for different things, but it's not that we're insisting they take 0 hours contract to benefit the organisation. Most people on the bank do many hours per week, and certainly do many hours per month, and absolutely complement the permanent workforce we have, but they do it in a flexible way that suits their home circumstances and certainly benefits the hospital as well. And then the final question, I think, was about joint recruitment. I think as we go into integrating our services more around populations and geographies, our public services have to think about integrating roles and making joint appointments, certainly as we go from the hospital care to healthcare and step down care and care around nursing homes. It's an option for us to think about that. At the moment, we spend time trying to recruit members of staff who often come from different sectors in the public services and then rotate back round. So it's counterintuitive sometimes that we don't have joint roles in the health and care environment, but it's something we've got to get more. We've got to do more on, and certainly do more to support the workforce to work in those different roles if they want to. Thank you.
Thank you very much for both of the items this afternoon. I will just note the national living wage and the real living wage are different, so please don't come back and answer that, but we ask you to ponder it because that is our aspiration. But many of the issues that you've got there are common to other health partners and to ourselves as an authority. So to have an insight into that and how you're dealing with it was extremely useful to us. Once again, I would like to thank you, Caroline, for the quarterly meetings that we have and the fact that you've been today before the whole committee. So thank you so much for that, and we look forward to seeing you soon. The recommendation committee is that we note the pressure on the Trust workforce during the pandemic and note the measures taken by the Trust to support staff and a positive staff experience. Everyone happy with that? Looking for nods. I'm getting them online as well. That's fantastic. So thank you for that item. Kate, can we try and do this a bit quickly because we're slightly behind? And before I introduce you to introduce the report, we're looking to set up a task and finish group, as everyone will have seen from the report. Possibly, open-minded, see what people say, but possibly with 3 members, 1 from each group represented here. I know Councillor Murphy may well be interested from the Lib Dem group, but could the Labour group and the Conservative group think, as we listen to Kate, whether there might be a volunteer there who wants to take this role? And the Vice Chair and I have been thinking that it wouldn't be us and that we'd try to spread. Have we thought that? It might be me. That will depend on the Labour group, of course. Very, very democratic. But we'll consider that after listening to Kate. And that just gives you a bit of warning to think about it as she speaks. Kate.
Thank you. Yes, and I'll try and keep this as brief as I can. So as a scrutiny committee, provider and acute NHS trusts have a statutory requirement for their quality accounts to be considered by yourselves as a committee. And the comments that the committee would be made need to be part of their published document that goes to NHS England and NHS England / improvement. The issue that we have, and this is what we're faced with every year, is that the timescales are incredibly tight. So we don't start receiving draft quality accounts from our provider trusts until around April, and they have to respond to NHS England and take it through their own boards by the middle of May. So that's why every year I miss
Kate, I'm really sorry, but it's been good so far, but suddenly it's got not so good in terms of sound quality. Could you turn your camera off and just go back about 3 or 4 sentences and continue? Thanks.
Yep, hopefully that's a bit better. Okay.
It is.
Lovely, thank you. So just to kind of go back a few sentences then, the issue that we've had in the past is the timescales are incredibly tight. NHS England and Improvement require the trusts to submit their final version in May. So we have the situation every year where I bring, because of our timescales that we've always had, I have to request that we put a task and finish group together, because scrutiny has to be done. It's member-led, so it has to be done through yourselves as elected members, and that's basically what the paper is. Potentially, we would be receiving 6 quality accounts. They are large documents. We don't always get the 6. And my suggestion to you is that we set a timescale. I'll communicate with the trusts and we'll set a timescale. And if we haven't received a draft by that time, then we'll say that we actually won't respond to them, because obviously for yourselves as members, it would be quite tight. And then the final point to make is that we'd bring any response that we submit on behalf of the committee would be brought back just to this committee so that you can see what was said. But you're actually being asked to delegate that responsibility to that task group. I'm happy to take questions.
Thank you. For members of the former Health Committee, this is just a regular annual occurrence. But other members, this may be new to you. Councillor van der Ven.
Thanks. I'm not actually putting my hand up to be part of the task and finish group, but actually to say, having done this, I think last year or the year before, I thought it would be the accounts, i.e. the financial accounts. It's not. These are really interesting, very, I would say, holistic accounting of an organization's accounting of itself. So a lot of the stuff that we just heard in the scrutiny item with Hinchingbrook Hospital, for example, the freedom to speak out freedom to speak up program, there's a lot of detail around how the hospital functions and the environment for staff and all sorts of things. And it is actually a fascinating oversight of the life of a hospital or of an NHS provider. And so I would just encourage anyone who might be interested to have a go. I enjoyed it a lot. So there we go.
And I made that mistake originally thinking it was financial accounts, and it's not. It's an extension of the scrutiny function. Obviously, we'd be supported by Kate. Councillor Slatter, please.
Just wondering, Chair, whether there'd be a good case for opening this opportunity to other members who aren't members of this committee. Because sometimes a fresh eye, some will come having had experience on health committees of one sort or another in the past, or on district councils maybe, or just from their own life. I just wonder whether that actually might work quite well, because some of us are already going to your liaison groups, and sometimes we think we know it already, and then we don't really. But somebody coming with a fresh eye and assessing it and asking maybe different questions, maybe it might be able to play a part. But obviously, the people organising it are the best judges of that.
Yeah, just to respond immediately, I'm not against that. But I think transitioning to an integrated adults and health committee, it's quite good to build up the capacity and the learning on these issues within the committee, and for people to bring what they've learned back into the committee. But I hear the suggestion. Let's see what other people say and where we get to.
Well, that would be lovely. Unfortunately, due to training and everything, that's actually against the Constitution. So sorry.
You see, Dan's been replaced by Rhiannon this afternoon. Dan's been replaced by Rhiannon this afternoon, and she's much more tough on the Constitution. So good for her.
Pity, because I think members don't know enough, really.
Okay, that was a light-hearted exchange. Anyone else on this? Can I just see if we've got volunteers? Is it true that Councillor Murphy would be happy to do this?
Yes, indeed. I've read quality accounts before. In fact, I've helped write some. They are genuinely really interesting.
Thank you. I don't, of course, any other Lib Dem is happy to volunteer. I'm not closing that down. Can I look at the Labour colleagues and the Conservative colleagues? Have we got if you want to take a second to consult with each other.
Chairman, Councillor Steve Turney, sorry, Steve, are you interested in this?
Councillor Corney. Well, thank you. That's really great. Thank you so much. So there's one laggard group and they're all looking down. Are you, Councillor Gay's willing to do it? Oh, tremendous. Tremendous. For members of the public, we're trying to spread the responsibilities around. It's a good democratic thing to do and to really involve everyone in the committee. So that's fantastic that each of the groups have put someone forward. Thank you so much for doing that. Really, really good. Okay, Kate, did you want to come back at all, or can we move forward?
You can move forward. Thank you.
Thank you very much. We know, you know, we ask you everything on health scrutiny and don't act without your advice. Thank you very, very much. So the recommendations are to note the requirement for NHS provider trust to request comment from health scrutiny committees, to consider if the committee wishes to respond to the quality accounts we have, and to prioritise which quality accounts committee will respond to. We'll delegate that. I'm looking at Rhiannon. Is that okay if we say we delegate that to the task and finish group? Yes. Yeah. And we delegate to them as well the approval of the responses to the quality accounts under instruction from members. And we've appointed members of the tasker and finish group, and we'll name those in the minutes. Is that all okay, Rhiannon? Okay. Everyone happy with that? Nod at me if you are. I'm seeing that from both sides. Am I seeing it on screen? I am. Thank you very, very much. We did that quickly, but it's a really important piece of work. Delighted also. We now moved, just checking where we're on time, not too bad at all, to a really important issue that we've been wanting to raise for some time, which is issues about children's and young people's mental health provision. It's the last item on today's agenda, item 18, and it's on pages 313 to 328 of the agenda pack. Once again, I welcome Councillors Goodliffe and Hoy, and can I just inform the committee, I will ask them to speak first after we've heard the presentation and have the first chance to comment. Everyone welcome and encouraged to contribute, but I will ask them first and thank them again for participating. We're joined by, I hope, Catherine Cruz. I'm just looking at the screen. We are marvellous. Head of Children and Young People's Mental Health Commissioning and Transformation at NHS Cambridgeshire and Peterborough CCG. Catherine, you're very welcome, and we look forward to presenting the report that's in our pack. Sorry, just hold a second. We've got another person I should welcome. Carleen Allen is on the screen, and Carleen, you're also welcome, and I'll ask you to add anything after Catherine has spoken. Thank you to both of you. Catherine first, please.
Thank you very much, and thank you for this opportunity to come and talk to you about the work that we've been doing across Cambridgeshire and Peterborough around children and young people's mental health. As you'll see from the paper, there's quite an extensive amount of information, so I shall just run through some key points and then hopefully leave opportunity for discussion, as I imagine there'll be quite a few points. So firstly, to make you aware that across children and young people's mental health, we've been working really hard over the last few months to look at our mental health strategy. So we've had a local transformation plan across Cambridgeshire and Peterborough for the last 5 years, and that has sort of detailed our priorities, our aims and our visions. That came to an end at the end of 2021, and so we're now working to look at what our next 3 to 5 year priorities are. And we've done lots of engagement with stakeholders, so with children, young people, families, lots of different professional groups around what they see are the key issues across Cambridgeshire and Peterborough for children and young people's mental health, and what we need to sort of focus on going forward. Where the new strategy changes from the local transformation plan is that this strategy goes up to 25. So obviously it's been an adult committee. This links in, and we're working really closely with our adult mental health commissioning colleagues to make sure that what we do within this strategy works and aligns with what they're doing going forward. And as you'll note in the paper there are sort of a number of key areas of challenge that have been identified during that work. And one of those is around the support for 16 to 25-year-olds, as often that becomes a challenge area as they transition between children's and adult services. I'll then move you through to just highlight around our emotional health and wellbeing service. So this is a service that's been in place for a while and is a team that encompasses 3 main areas. So that's around emotional health practitioners. So that's a set of workforce where professionals, mainly schools, but also GPs or social care, if they want advice and guidance on what to do, or how to support and help young people, children, young people with their mental health, they can refer to them and they will have conversations on an individual young person, or maybe there might be a theme within a particular school that they want to address, so they can help with that. If they then identify that a young person might need some specific interventions, they move through to getting support from the children's wellbeing practitioners. And then we have mental health support teams in schools. These are a real key part of a national drive to improve and increase the access to early intervention support across schools. And across Cambridgeshire and Peterborough, we have 6, and we are currently just going through the finalising another further 2 teams that will be starting in January next year. And as you'll see, there's a mix across delivery across Cambridgeshire, and we've been focusing on, we've got some in a team in Cambridge. We've got one in Wisbech, and now we're looking at the ones that just started in Whittlesea, March and Chatteris to cover that area. They work to deliver a range of evidence-based interventions. They also work with the leads in schools. They also work with further education colleges, so they will pick up the 16 to 18-year-old young people. And then they will also work on what we call the whole school approach. So thinking about the education setting, how they make sure that they are sort of emotionally well-being place, and thinking about this, it's about staff well-being as well as the young people that are educated there. Then refer you through to point 2.3, which is United. So United is our new early intervention service that came into being on the 1st July 2021, and it's jointly commissioned between Cambridgeshire County Council, Peterborough City Council and the CCG to deliver a range of early interventions. One of the key parts of United is we brought the voluntary sector and the statutory sector to think about how we can streamline some of them pathways, because we were aware that we needed to make sure we look at how referrals come into the system. So you'll note in the paper about there's a referral hub where referrals come into, and that could be for child and adolescent mental health services, but also for other early intervention provision. We've also noted in there the referral numbers. So when we did the modelling around this, we were thinking about 650 per month. We have had more than that over other months, and looking at December, which we naturally see as quite a quiet month for referrals because of holidays, there were quite a number. So overall, we are seeing increase in demand for services across the spectrum of need, from early intervention up to specialists. The paper then goes on to note some other services. So COOTH is a provision we've had across Cambridgeshire and Peterborough for a few years, and as that says, that goes up to 19. So again, so for young people, that will support them, and that's an online provision where young people can access out of hours or at weekends advice. There's forums on there, and there's also a messaging and a counselling provision in there. The paper also notes about children and adolescent mental health services, which are provided through CPFT, and we've been working with them to think about how we can improve the flow of children getting into services. So they are now part of the United Hub. So if a referral is required to go to CAMS, it will also go in, and this is to help, let's say, streamline, because what we were finding is young people were referring to multiple services. So this is thinking about how we can bring those services together to stop people having multiple referrals. Point 2.6 on the paper talks about our eating disorder service. So during COVID, we have seen a significant increase in the number of young people who have been referred to eating disorder services, and as well as the increase in the numbers, the complexity and the acuity of children, young people who are presenting have increased as well. This has had an impact on teams and their ability to see and support young people, because they are seeing more complex young people in the community than they would have seen before. And as noted in the paper, there is a national shortage of tier 4, so that's the inpatient beds for mental health. there has been a reduction of availability of beds, and that has meant that there's an increase in the complexity and acuity that's supported in the community. There's data in there that demonstrates that there is a struggle across Cambridge and Peterborough, but also across the east of England about seeing people with eating disorders in a timely way. And that's something we're working really closely with the services to help and make sure that we can support young children, young people as much as possible. I think it is really important to note that although the teams are under a lot of pressure in terms of the numbers that are coming through and say the acuity of children who are presenting, they are still working hard to look at how we can transform services, because there's a real acknowledgement across the system that if we don't continue to work and think about how we transform and develop services, we need to move forward. So there is still work going on. They've over the past year implemented a home treatment pathway, so that's to support young people who previously might have ended up in a tier 4 bed, or those who are coming out and need a bit more intensive home treatment and to be seen more regularly. So that's been set up. We're looking at the medical monitoring, so that's around working with GPs and primary care to think about how you do some of that physical monitoring for children and young people with eating disorders. And also we're starting to look at ARFID, which is avoidance restrictive food intake disorder, and that's a slightly different focus around eating disorders than anorexia. So that's often around sensory issues with food and can be quite complex and often impacts on lots of different parts of the system. In addition to service developments around eating disorders, from April last year, we've now got a CAMHS crisis assessment service. So that's a dedicated assessment team that will carry out assessments of children and young people who present either to the first response service, which is NHS 111 option 2, or to A&E in a mental health crisis, and then they will be assessed and supported. In addition to this, we have developed a home treatment team which provides support, intensive support for people at home, sort of following if you've had a crisis assessment and actually you need more intense support for a set period of time. So that's become really, it's a team that's building its capacity. And I just note for both the crisis and across all services, workforce is a challenge, and many of these services have had to start without their full complement of workforce than what we would ideally want. But actually the note is that actually it's really important to start this transformation and get this work going forward. So we're building up capacity in a number of these teams, and workforce across mental health is something that is not just known to Cambridge and Peterborough. It's a national issue around the gaps in workforce, but we're working really hard with NHS England and Health Education England and looking with education providers how we can do that, and thinking about different models and just thinking about different solutions to workforce challenges. The paper then goes on to talk about the first response services. I just noted that's our crisis 24/7 response. So that's an all age response for anybody who's in mental health crisis. And then also notes about inpatient provision. That's not something that's a CCG we commission. That's commissioned on a regional basis, but we do work closely with them. We obviously want to make sure that the pathways and the flow of children who are in an inpatient bed and moving into the community is as effective as possible. Then move forward into neurodevelopmental pathways. So this is a service that provides a diagnosis and support for those with autism, and those with ADHD or a learning disability. They provide a multidisciplinary approach, and they also work really closely with our early help colleagues to make sure that we've got correct family and parental support. So there's a pathway that goes through to make sure that it's, you're getting early help support and parenting support, and then you move through to a diagnosis if that's the right thing for that child and family. We've got quite a strong voluntary sector collaboration called Full State around children and young people's mental health. And they've been very much involved in a lot of these initiatives that I've spoken through. Notably, the United, they've been working, although they're not in the partnership, they've been working quite well with other partners, and they deliver a real, their sort of mission is to think about how we bring strength in the voluntary sector and how we can improve equity of access for children and young people. And they have been involved in some other small initiatives around thinking about some projects. Notably, one of them is Young People's Counselling Service. So that works in the Whittlesea, Ramsey, Wisbech area, and they've been really helpful in sort of thinking about delivering different options and different ways of supporting young people. The paper then goes on to talk about digital support. So one of the things we found over COVID is that there's quite a lot of national options, and there's lots of ways we can support young people through digital options. And it's almost, to me, it's to the way we as a system see it is that it's a choice in the menu of interventions. So as part of United, there are face-to-face, there are group, but then there are also digital options available to think about what's the most effective model of delivering a support for children and young people. Some have really taken on board and responded well to digital, others still prefer face-to-face or group. The paper then just to talk you through a few of the other school-based. So this paper mainly details the commission services from our perspective, from the CCG's perspective and from the local authorities. However, there is a huge amount of work and activity that goes on in schools and education settings around mental health support. Some of that is, as these initiatives will outline, are looked at across, and some are very much individual settings. They've got their own sort of support, and they look at various ways of sort of buying in and supporting young people's mental health. So to support them, we've developed a mental health competency framework, and that's very much to make sure that the staff feel that they've got the competence to support children and young people with their mental health and well-being. We've also looked at a huge, vast amount of resources, and we've tried to consolidate that to help schools know where to go for information and advice. And then there was the National Department of Education funding to help support young people. And then, as it notes in the paper, there are some sessions that are focusing on trauma and also thinking about how we can support the staff in schools. So there are forums that are set up regularly to enable that school staff have got the support for their mental health and well-being when they're supporting children and young people's mental health and well-being. The paper then goes on to talk about access targets and outcome measures. So one of the key metrics around children and young people's mental health is that we know that the number of young people who access support was low, and therefore a measure is around how we increase access. So the paper details that the starting point was 25% in 2017, and actually the national ask and Cambridge and Peterborough achieved was to see 35% of young people who had a diagnosable, what they class as diagnosable mental health problem by 2021. And that continues to be a national metric around how we continue to increase the number of children and young people. So now the next phase is around how we ensure that we're achieving positive outcomes for children and young people. So work is going on at the moment about how we collate, how we use, collate, and measure, and then be able to demonstrate the use of outcomes and how we've improved the outcomes of children and young people. We've still got work to do on this, but that's where there's some work going on at the moment. The next section talks about investment. So across Cambridgeshire and Peterborough, there has been a challenge in investment. We are one of the lowest spends per head of population across the eastern region. We've been working very hard in our team and with local authority colleagues to think about and make sure that we put the case forward around children and young people's mental health and how we can increase investment into that. And the table in the paper just demonstrates a few areas, and that's similar to what I've spoken to previously about the areas that we've focused, and it just gives some detail around the numbers. So to conclude, so this paper does set out a range of initiatives. As I say, this focuses on those that have been commissioned by the CCG and the local authorities, and it does make note to some of the voluntary sector. There are lots of other small groups and small organisations that are supporting children and young people's mental health and well-being, notably a lot of work that's going on in individual schools. There has been a huge demand for children and young people's mental health, and the complexity of need has increased, and certainly COVID has accelerated that. But we are working hard, and we are continually thinking about how we can transform services and develop them to improve the mental health and wellbeing of our children and young people. So thank you.
Thank you very much. I think we are going, thank you for such a thorough presentation, but I think that means we will slightly overrun. I'm going to take Councillor Goodliffe and Councillor Hoy first and give them 5 minutes, but I'm going to suggest it's 2 minutes each for the rest of us. It's only a suggestion, but to try and get as many people in as possible, because I know this is an issue of interest to many of us. First, Councillor Goodliffe.
Thank you. So if I start with the local transformation plan, I've got a few questions there. So the key themes from 2015, there were 5, but then looking at the current risks and issues on page 38, obviously a lot of those tie into what we had as key themes in 2015. So I'm interested in has there been any movement since 2015, or are we in a very similar position to then? 2015, the target of 70,000 more children and young people having access to high quality mental health care was mentioned. How did we manage with that target, would be my question. Page 35, it's the CPFT CAMS data. Talks about young people sitting on the assessment waiting list. Do they then go on to the treatment waiting list? So does this run concurrently, or is it a sort of one after the other type thing? And where we have re-referrals within a given time frame, I'd say between 1 to 2 years, do we have a measure for this, for those who didn't meet assessment criteria in the first place, but are then re-referred and taken on by the service? In the crisis referral information, it says that there is no 111 option 2 in Wisbech. I'd like to ask why that is, please, and if we can have that adjusted with our 111 system. And then going to the report, so 2.2, the emotional health and wellbeing. It says here that with primary age children, we mostly work with children and with parents and carers rather than children. Can I ask again why we do this and what evidence is used for this? 2.10 is the neurodevelopmental pathways. Do we have a number of children and young people on the waiting list for this, and a mean waiting time for assessment and diagnosis? And is this the only place where children and young people who have comorbidity of issues can be seen? For example, if a child with autism also has ARFID, can they access the ARFID system alone, or do they only get seen under the autism service? And then do we have a specific assessment and diagnosis speciality for older girls, particularly who are on the autism waiting list? I know it's a very specific issue, but it's also one where we have a lot of children and young people who are diagnosed very, very late due to the differences in their presentation. 2.11, our brilliant voluntary sector, who we work brilliantly with, but also give an awful lot to our county. Who oversees the voluntary sector to ensure that this work is delivered by professionals with access to both training, support and professional supervision? And then finally from me, school-based support. Do we have a delivery date for the report of the local offer from, I think it's the YMCA on that one? Thank you, Chair.
Thank you. I think to be fair all round, what I'm going to do is take Councillor Hoy, and then I'm going to ask Catherine for you to respond, because otherwise you're going to have such a length of questions. I think it'll be impossible. So if it's okay with you, Catherine, I'll take 2 rounds. Round 1 from our CYP colleagues, then round 2 from other members present. I also made an error earlier. I didn't welcome Councillor Sam Clark from Fenland District Council. You're quite dark on our screen, and I thought it was Sam Boy, so I'm really, really sorry about that. But you're indeed welcome. And in the room, we've got Councillor Garvey, who I don't think I welcomed at the beginning. So welcome to you as well. And the role of our district colleagues in this is really, really important. Having said that, I do want Councillor Hoy to come next, please.
Thank you, Chairman. I'll just keep my points brief. A few questions, really. Councillor Goodliffe just mentioned the 111 option 2, and I was glad she did, because I mentioned that over a year ago about it not working in Wisbech, and kind of didn't really get any response. And then I contacted Val Thomas about a young person with a mental health issue and was told to tell the family to call 111 option 2. And obviously, that wasn't necessarily the most helpful advice given that it's not working. So I suppose, how urgently can we get that working? Because it's just been going on too long now. My other point was regarding the voluntary sector. Obviously it's referenced in the report, but it's not clear just how many people they support and how reliant we are on them, really. I think we might be surprised at just how much work they do and how many people they are helping. And it would be useful to see, I don't know, going forward, either in a later report or at another meeting, how we're going to help, I suppose, the voluntary sector, because I'm aware a number of them are due to run out of funding within the next year or two. And it worries me that I don't want those children to fall off a cliff edge when funding's withdrawn. Just a point on there, you mentioned the school practitioners. The feedback I've actually had from schools has been quite poor, I have to be honest. They're saying that with the practitioners, they're referring people to them and they're being told, oh, sorry, we can't help, they're too high need, and kind of they're not having the referral, or they're saying they're not high need enough. So I think the frustration from head teachers that I've spoken to is kind of what children are suitable for this scheme. So that's that. And then just a quick one for perhaps Richard or Charlotte, really. I suppose it was just, what are the next steps after today? Because obviously we've got this report, which is very welcome, but how do we continue to scrutinise it going forward, ensuring that the hubs are open? How do we try and encourage CCG to give more funding to this? And it'd be quite useful, I don't know whether it has to be looked at by this committee or by CYP, sort of looking at the link between mental health and its prevention in our sort of children in care, because obviously we spend a great deal of our budget on children in care. And if we can kind of prevent children from coming into care by improving their mental health at an earlier stage, would that make a difference? So it'd be quite useful to have a look at that going forwards. Thank you.
Thank you. On that last question, I will ask Charlotte to reply, so you will get an answer at the end of the session. So I'm going to break there and go back to Catherine to answer the questions that have been put to you so far, please.
Thank you. In regards to the questions about the local transformation plan, I would need to go back specifically to look at the points and can I just check, was it about, when you know, to page 38, was that specifically within the local transformation plan that those points were being raised to?
Yes, it was, yeah.
Yeah, so I don't have that document in front of me, so I'll need to go back and have a look at that so I can come back to you on those specific points, if that's okay. I can answer the one about the access target. So yes, the national measure was for 70,000. For Cambridgeshire and Peterborough, that equated to approximately 5,806, if memory serves me correct, children and young people by the end of 2021. And we did achieve that target. So we actually saw the measure was 35% and we saw 36.1%. So we did achieve our element of the national ask of increasing that. But now we need to continue to increase it, but we did achieve that. So I need to have a look at the re-referral data and the CAMS data list, and then I can come back to you on that. The point about the NHS 111 option 2, I am aware that there was an issue in Wisbech, but I would need to go back to my colleagues in the adult team who commissioned that to understand if that continues to be an option, an issue, sorry, because I'm not sure if that's still an outstanding issue, but I know it was something to do with the telephone, the towers and where numbers were picked up, but I don't know the outcome. So again, need to go back to colleagues around that. Around the emotional health and well-being and working with primary school age, where it says primary school, it is mainly those under 8 to 9. And I would, again, I'm not a practitioner, so I'd need to go back and speak to those. But the evidence is that if you work with the families and think about the parents and how they can then support, that's the evidence base that they use, although they will work with children directly as well. But for those sort of under 8, they tend to work with the families to make sure that they have the skills to work with their children, young people, to support them. Again, this is the point around the neuro list and the mean waiting times. I don't have that data to hand at the moment. During COVID, the reporting of our data has been impacted by the impacts of COVID and national guidance around NHS contracting and reporting. So some of the information we have been getting hasn't been as timely, so we need to go back and get that. And was there if there's a specific time frame you were looking at, that would be useful as well. The other point around ARFID and ASD. So ARFID is quite a complex issue in that children can be supported across various different services with this condition. So they could be seen within, it could be identified through their autism diagnosis. It could be seen through, if they've got through speech and language therapy, if it's sort of a post-choking issue. So it's complicated. They could be seen within the ASD service, or they could be seen by others. So they could be seen by the dietitians in the community or by the community paediatricians. So it's not to say that they will only be seen by one, because it actually depends on where and the severity of their need depends on where they're seen and supported. The issue about access to diagnosis for older girls with autism. So alongside the work we've been doing around mental health, there is an all-age autism strategy for Cambridgeshire and Peterborough that's been agreed, and within that there is a work stream looking at diagnosis. So that's the area that we'll be focusing on, looking at the pathways around diagnosis. And I know that's a piece of work that's going. So I think that if there was further work that this committee would be interested in that, then that's probably something that could come back to this committee at a future point. So then to your voluntary sector and who oversees this sector. So we will obviously oversee those voluntary sector organisations who we commission. But I don't know if Carleen has any thoughts and wants to add in around those that we don't commission and where they're seen by.
Thanks, Catherine. And for those of you that don't know me, I'm Carleen Allen. I'm Deputy Director for Maternity and Children's Commissioning in the CCG. So the voluntary sector, we would liaise closely with Healthwatch and with our contacts, Julie Farrow in Health Hunts Forum as well. But other than that, we don't have oversight of non-commissioned services. That would be a piece of work that we would need to understand the impact if they weren't commissioned any longer.
And then the last point I had was around school-based support and the local offer. Could you just expand on what your question was in regards to that, please?
Yeah, sorry, it's 2.13. You talk about the report of the local offer that YMCA are putting together. Do you have a delivery date for that?
Oh, right. Yes. Sorry. Yes, that makes sense. So I'll go back to my public health colleagues. So they were the one who commissioned YMCA to do that piece of work. I know there had been some delays in that due to COVID and some of the piece of work that didn't happen in schools because they weren't able to go in and support. But I can find out where the current position is of that.
Okay, thank you. We'll now move to the second round of questions, and Councillor Daunton is first.
Thank you. Well, first of all, a comment. Councillor van der Ven and I have our regular liaison meetings with CPFT, which I found very useful as a governor of CPFT, and I think that they've got a really good new holistic approach of physical and mental health, looking at things in the round. My question really is about the users of the service and whether, how and when are we able to listen to hear how they receive the services? Are there mechanisms for doing that? And then very specifically about schools, working in schools. Is it possible to have a scheme of ambassadors, school age ambassadors, mental health ambassadors? And are schools able to look at ways in which they can use art, drama, music to deal with the issues of mental health. I would have thought that that would be a really important message to a way of dealing with the issues.
Thank you. Councillor Hay, please.
Thank you, Chair. Over the last couple of months, I have seen programmes on the television documenting out children and young people who have been put into mental health beds, where parents initially thought they were going in for respite care. The ones I'm talking about in particular suffered from autism, only to find that they're still there several years later. What I would have liked to have seen is some data within this report showing us how many, if any, children and young people from Cambridgeshire have been taking up an inpatient mental health bed for long periods of time, exactly how many children and young people we currently have taking up inpatient mental health beds, and has it increased over the period of the pandemic, and are Cambridge children and young people in facilities within Cambridgeshire, or by necessity, are they housed in mental health beds outside the county? And if so, how far outside the county? Those are my questions.
Thank you for those important questions. Councillor van der Ven.
Thank you. Thank you for the paper and the presentation. I wanted to ask a question about the mental health strategy. The paper tells us that the strategy focuses on those with a diagnosable mental health concern, but we know that we have absolutely horrendous waiting lists. So there are thousands of children out there without a diagnosis. So I guess my question really is, what is the strategy for dealing with that enormous waiting list and problems that will obviously exacerbate, and those are sort of out of, I find my reading of the paper was that is not, that is sort of, I don't see that being tackled through the transformation plan, and maybe I've missed something, but what's going to change? How are we going? And it's a huge question. There are so many different services here, and absolutely recognize all of the issues around staffing and so on. So just your thoughts about that would be really great. Thanks.
And for me, I absolutely endorse what you said. I'm sure you and all your colleagues are working very hard, and it's good way you've acknowledged the challenges in the report and in your presentation today. But I have to say this is one of the areas where, from my experience, just amongst people I know and people I represent in the area where I live, the system is completely letting down young people at the moment. And I'm sorry to say that, but it's important you hear the feedback. I think my colleague Councillor Goodliffe has said about some of the special needs in terms of older girls. But I definitely give you feedback that there's a mental health crisis amongst older boys at the moment, and it seems to have been exacerbated really badly during the COVID crisis. And they're just not accessing the service, and the service is just not accessible. I know of one case where it was referred to CAMS, the referral was accepted, and then 6 or 7 months later, when the young person gets to the top of the list, they're told because it's to do with post-traumatic stress that the service can't provide for them, and yet the alternative service, they didn't meet the criteria. And so someone with quite serious mental health issues was essentially rejected by the system. And I don't really accept that the hub solves that, because you had a system before which allowed referrals to go to the right or the wrong place, and CAMS accepted that referral and then was clearly unable to meet it. I think this is a issue which is of deep and high concern to this committee and to this council. We thank you obviously for taking part in this dialogue, because it's part of a process which hopefully can support and engage with you to resolve some of those problems. but it would be a dereliction of our duty if we met today, have these deep and abiding concerns about the failure of the service and its failure to young people and not pass that on to you. Catherine.
Thank you for your comments. I'll work through them. So the first was around about service users and how do we listen. So we've got 2 parent carer forums across Cambridgeshire and Peterborough, Family Voice, Peterborough and Pinpoint, and they work really closely and they sit on our Children and Young People's Mental Health Board, and we regularly meet with them, and they help bring the voice of the family to what we do, and they're very, very involved in our work around the strategy. We've also been working with some young people's groups. So there is a co-production group as part of the United Service Development. So they've been really key. So young people, they came up with the name United, they developed the logo, and they've been really engaged in our strategy work as well. So we've had engagement by over 120 young people in that work. So we've been working really hard to get the voice of young people involved. There's always more that we can do on that, and I think trying to broaden out who we get views from is really important. But we are starting. We do really understand the importance around getting the voice of those who use the service to be part of that and help us think about and be part of a co-produced way, think about how we move forward with these services. I think it's interesting about the school age ambassadors, and I know that in certain pockets around the county there are groups that are very vocal, and one of the piece of work we've been talking with the organisation who've been helping us with our strategy is how do we continue to build on those relationships with those young people and get them moving, to help us, and whether we think about them in some sort of chairing role as our board. There's various different options we're looking at, so that's how they're sort of involved at the moment. And I think alternatives sort of around art and drama is very interesting. So there is some provision around music therapy within Cambridgeshire County Council. There are various different sectors that will provide support, and I know that some schools will, they have various different support that they bring in around the sort of the arts and as a way of helping support young people. Next question was around beds. So as I noted, we don't commission the beds, and I don't have the data to say how many people are in our tier 4 beds, and the length of stay that young people are in beds does vary. In question around, are they inside or outside? So we have some of our young people are based in Cambridgeshire and some are based outside, and that's around the needs of the young people and the beds that we have and whether they've got the right skills and to support young people in the right way. I imagine Carleen might want to come in and further on the work around the work that we're doing around those who are in inpatient beds.
Thanks, Catherine. I just wanted to update you that we do have a regular monthly 0 to 25 complex cases meeting where we discuss all of the young people that are in an inpatient bed to try and identify solutions as a system to how we can bring those children out of hospital and back into their home environment or into a local solution. We currently have 15 in inpatient beds, but not all of those have autism. So we've got 4 children currently that have autism that are in inpatient beds with severe challenging behaviour. One particular child that has been in hospital for a very long time, and we are working as a local system to build a property for that child in the local area and bring that child home so that he can be close to his family. So we are also working very closely with provider collaboratives to look at how we manage inpatient facilities, and as part of the new children's hospital work, there is a collaborative approach to mental health and physical health, and making sure that we've got beds in county in the new Cambridge hospital that is being built. But the main aim that we are trying to achieve through the provider collaborative is how do we develop the community services and strengthen them to be able to manage these children in the community rather than them being hospital, which is the best place for them. And so the ideal is for them not to go into hospital in the first place. But in order to do that, we need to make sure that we've got the right level of skill and resource in the community to manage the acuity and complexity of some of these young people. Thanks, Catherine.
Thank you. I'll move on to the point about the strategy. So when we were developing the strategy, so it's looking at those with a diagnosable. It doesn't necessarily mean that someone has to have a diagnosis. So the strategy is focusing on those children, young people, as when it's identified that they need help, that they would then go on and they may have a diagnosis. It's those that need help. And I guess where it separates is that in public health at the moment, they're currently looking at a prevention strategy. So that strategy will cover the preventative element. And this is when the point actually it's moved beyond prevention and somebody needs help. So this strategy is working from that point that a young person is identified as needing help. Waiting lists is a challenge. It has been a challenge for a number of years, and COVID has exacerbated some of that challenge. We are working hard with our providers to think about different ways about how we support and how we can get young people and children, young people seen in a timely way. That continues to be a challenge and will be a challenge for a while because of the demand for support, because of the workforce challenges we have. We are looking at whether they've been developing through United some webinars to get information, advice, so while people are waiting, they're still getting some support. So we are looking at ways of doing that as well, because we're very aware that actually while people are waiting, it can be really difficult for them, and therefore how can we give them information and support in a way that can help them through that. I think there's probably further work that still needs to do on that, and it's something we're very aware of and we are working with our providers to do. To the last point about the help and the number of children who have been impacted COVID, and you noted specifically older boys. Certainly when we've looked at the information that we've looked at around our strategy, we have seen there are certain groups that have really been affected and continue to be affected. And we work with services that we do need to continue to make improvements. We have been, and say Carleen and I work really hard to raise the profile of children's mental health and make sure that we, every opportunity, can work hard to get resources. It continues to be a challenge, but it is something we are determined to keep doing, and we thank this committee for their support in doing that and holding the system to account around what are we doing around improving and making real improvements. I feel we have come away, but we've still got quite a long way to go to make it better for children and young people across our area.
If I could just, apologies, if I could just add to that as well. Thank you, Catherine. Obviously we can't discuss individual cases in a meeting like this, but if there are particular individual cases like the one that you alluded to, then we would be very happy to pick that up outside and follow that up to understand the learning from that scenario so that we can ensure that we address that from a commissioning angle.
Thank you both, and thank you, Carleen, for what you said at the end there. I think you've been admirably open and candid in talking with us, and I think that's really helpful to this process, and we very much respect that, and we also very much respect the fact that this is not about attacking or criticising individuals. This is about system successes and system failures, and that this process is meant to assist in that task. I think we've heard in the debate from Councillor Goodliff that some of the aspirations in 2015, there are huge question marks about whether they were realised, and we've heard from yourselves that there is underinvestment in this area very, very clearly, and you've produced the figures in this report. And I hope our committee has made clear that the level of unmet demand, the level of the waiting list is unacceptably high, and I guess many of your colleagues would agree with that. Whether you would be allowed to publicly or not is another matter. I was asked a question, or we were asked a question by Councillor Hoy about next steps. I'm going to ask Charlotte Black to answer that, please.
Yeah, certainly. Thank you. And just to confirm to the committee that we do work really closely together on this agenda. We've got, as Catherine said, we do have a regular meeting of the 0 to 25 children with complex needs, and that's a meeting that I chair because often there is quite considerable levels of social care and education involvement, and we want education involvement in many for many of these children. So, and I've been really impressed by the way in which the professionals are working together with the resources that they've got, but that doesn't in any way underplay. I think that this is a really critical issue, as you've all said. So I think in terms of next steps, I think the my suggestion would be actually, and I think Catherine in a way has confirmed this, is actually it would be helpful to bring regular updates back to scrutiny about this work as it progresses. I think the Children and Young People's Committee is definitely the place to hear specific concrete proposals for the way in which we work together, and certainly some of those will start to emerge under the auspices of the integrated care system and the collaborative, which Carleen mentioned earlier, which is where we do much of this work. But it is important, I think, to differentiate between the areas that we can work together on and the areas where there is definitely a need for an increase in resource available in the community for children with diagnosable conditions. And so I think it would be helpful for scrutiny to continue to hear the feedback from Carleen and Catherine, and maybe to actually bring in some of the CPFT staff who are involved in that work as well, and to hear from them, because it's just such a crucial issue going forward. I think it's going to be one of the big ones.
Thank you. No, Councillor Goodliff was nodding at that, so Councillor Van was as well. So in turn, you asked about timescales, Catherine. Clearly, we need to complete a report based on today's discussion, and you've committed to come back to us on some areas where you need to consult your colleagues. So if you just can liaise with Kate Parker about that, so that we can ensure that information is received in a timely fashion and is able to contribute to the report that we produce, and then we'll consult with you about the best time scale where it would be constructive and useful to review this. We'll think about that internally ourselves, but also if you think about that, because we have had a full debate today and you've presented a report. So I think let's talk offline about when that's useful to do. But if we do say, and if we say in the minutes, please, Rhiannon, that we will review, come back to this and review it further in our health scrutiny function. It's obviously been a very important debate. Carleen, Catherine, thank you very, very much for your participation in that debate, and thank you again to Councillor Hoy and Councillor Goodliff. This was the last item on the agenda. The date of the next meeting, we've got the workshop in April, but the date of the next meeting of the committee is no less than the 14th of July, which is a long time from now. If people have got questions or comments, I know our officers are always pleased to hear from you, so don't wait until the 22nd of July if you want to raise something with our officers. But after a long, diverse, I hope successful day in terms of the committee, I now pronounce the meeting